I just sent it today.
Okay, calling the special committee to order. So today we have with us the director. Oh,
Hey Donovan, in case I forget, ask the question about the taxis, remind me.
It's
about which one?
About the taxis, they're putting people on the taxis
says
without
us,
telling
but
them that they're
it's not us.
positive. Remember I told you coming up? They're putting positive people on the taxis without telling them.
Oh, yeah.
I love all done.
Okay. Okay, calling the 2 p.m. Senate Special Committee to order. Today we have with us the Director Libby Char, Dr. Emily Roberson, and Dr. Sarah Kimball. On the agenda, we have the Safe Travels Program, the state's plan to distribute vaccines, CDC's recommendation for a second test upon arrival, and CDC's recommendation of shortening the quarantine from 14 to 10 days. But we also want to focus on the information on clusters and the dashboard. We want to make sure that we get the information out there so that we can prevent the holiday surge. So thank you for joining us.
I'm not gonna go through this whole thing.
Hi, good afternoon. Gonna let Dr. Kimball jump in first. We've got some slides to kind of walk through, quick presentation.
Is she just going to be real brief about it so that we can really get into the meat of
Yeah, I don't wanna
the
go through all
Q&A?
this general stuff again.
Yeah,
Okay. Okay, go ahead, Dr. Kimball.
Do I need to share my screen, or do you have a copy of the slides?
Well, it's on Olelo, so you might want to share your screen.
Go into all this stuff about-
All right, can you see that?
Yes.
Okay. I don't know if I can go to full screen, but if this works, I'll just run through. So just some highlights that I wanted to go over for Department of Health. We have had several areas of focus, one being data for action, another being development of the school metrics and on-site assessments, another is investigations and contact tracing, clinical partnerships, and then we'll close with just a few highlights of current department priorities. So we've been building a lot more data into the website, both the updated dashboard through HAIMA and this data story that we've been developing on the DocD website. So this is the URL for a lot of the information that I'm sharing in these slides and some of the data pieces that we've been working to develop over the last few months. This particular one is our epidemic curve that shows the course of the epidemic in Hawaii since March 2020. We've developed a set of metrics, 7-day average new cases and 7-day percent test positivity. And these have become a guidepost for us to look at where we're at and help plan for the next steps. And we also have developed other parts of the data story, such as travel-related data. So this has been an EpiCurve that we've tracked from the beginning, but we have refined it recently to divide out travel-related cases by resident and non-resident, and to be able to view and interact with this visualization county by county, so you can see what's going on in each individual county. We also have a table behind that, so you can get at the raw numbers for travel, resident and non-resident travelers, and this can also be viewed by county. We've also worked through developing the data pieces. This has become part of the ongoing discussion as we think about planning and implementing mitigation strategies for the pandemic and thinking about reopening. So Department of Health has been an active collaborator in discussions with the counties to develop reopening strategies and tiers. And these are examples of the Honolulu and Kauai reopening strategies that are based on those discussions, and give people a practical roadmap for what how their behavior should change at different phases of the pandemic or based on the case counts in Hawaii. This is helpful in a lot of ways because it helps people know what to expect and spells out practical considerations for how many people should be in a place at a time and how different businesses should think about how to operate safely. For schools, we've also worked closely through a school health advisory committee with DOE and private and charter schools as well, and the Hawai'i KP nurses to look at thresholds for different learning models and to talk, and really this discussion started with trying to draw some thresholds that give schools a guidepost for when do we move to more in-person learning, when do we need to back off. But the meat of this discussion really comes down to what are the things they need to do in their classrooms to make the school really a safer place than being in the community when it comes to COVID transmission. We have specific guidance for the kinds of interventions that can happen in the classroom to increase safety, how to implement Ohana bubbles and why that's important. And then over the last several weeks, we've gone into the field and been on site with DOE at a number of schools on multiple islands to see what's going on in the ground and to better understand how they're trying to implement the guidance. This has been hugely beneficial on both sides. We could see some of the pictures here show the hard work and great effort that the schools have put in and being really creative about how they develop guidance, signage, making sure they space out even the hallway. They make sure the hallway flow is correct and that you have the correct spacing for people to practice physical distancing, setting up stations to check people in when they come in. It also helps us to understand what some of the on-the-ground challenges are and makes us more effective when we have to work with them on clusters that occur in the schools. The next section, I'm going to pass over to Dr. Robertson, but we're going to talk a little bit about our current efforts with case investigation and contact tracing and address some questions about staffing as well. Dr. Robertson?
Thank you. Do you want to just advance the slides for me? Is that okay?
Sure. Just let me know when.
Great. So this is our current staffing as of this week for case investigation and contact tracing at the Department of Health, so statewide and by county. You can go to the next slide. This is more for reference in case anyone had any questions later. Also wanted to highlight some of the new performance metrics that we have up on the website that we're using to really determine how successful we're being or where our challenges are, where we need to work a little bit harder in terms of specifically being able to reach people who test positive and also contacts who are exposed to people who test positive. So this just shows one of the metrics that's on the website now, referring to the % of cases that we were able to reach. Next slide. When we are able to reach them, then these are just a couple examples of some of the materials and information that we're able to share with them. So giving them materials for themselves as well as materials that they can share with their close contacts and with others in the community. Next slide. We also posted this on the website this week, looking at specifically those that we're not able to reach to get a completed initial interview from. And so you can see here that we have, for the month of October, about 40% either just didn't answer the phone and also just didn't call us back after we left the messages. 40% had no phone number. There were some incorrect phone numbers, but in general, when you're able to get people on the phone, they would complete the interview. It was just more a matter of getting them on the phone. Next slide. This is a little bit more information about our progress over time. So improvements in timeliness of being able to reach individuals who tested positive for COVID-19. And so this is something that we're using internally as well as reporting externally to make sure that we don't have people that are not being reached in the appropriate time period to be able to really give them good directions for actions to prevent transmission further. Next slide. And this is another type of data output coming out of the case investigation and contact tracing operations. So this is this week's State of Hawaii weekly COVID-19 cluster report. And these cluster reports are published and made available on the website on a weekly basis. And we have a couple of sections. So the beginning part where you see on the left, that has some key updates, and it's typically organized by theme. So the theme this week were clusters that occurred in food production and distribution settings. And so being able to summarize what we've learned so far based on the clusters that we've investigated and what are messages that need to go out to individuals, to the community. In this case, we had some additional messaging that was really talking about business owners and our interaction with business owners. And then we also have the cluster tables, so for each county, saying what active clusters we have outside of just a regular household cluster. But you can see here that this week, this is the city and county of Honolulu. And so we're recording out case counts for 2 clusters that were occurring are occurring in correctional facilities, and 1 that is in a kind of construction industrial business type setting. And these exposure categories have been aligned to the reopening strategies that are being looked at and put into place by the county so that they can have information that is specific to the guidance they're giving to the community. So is there a distinction, for example, between bars and nightclubs and restaurants when they're giving their guidance to the communities and setting their policies? We wanted to make sure that we are reporting information out in a way that could be directly translated. Next slide. We also have a great deal of work going into clinical partnerships with regards to case investigation and contact tracing. One is that we've been working with the federally qualified health centers for a few months now, collaborating on case reporting, investigation, and contact tracing process improvements, streamlining, also capacity building, so doing training for staff of federally qualified health centers in different pieces of the case investigation and contact tracing picture. We have some pilot projects, specifically one pilot project that we're working on with KKV right now that is looking to test and evaluate some of our new and existing protocols to see if there's ways that we could incorporate things that they're doing at KKV into larger statewide recommendations, or also use additional information they have to provide a better picture of how our current protocols statewide are working. And then there's also projects that are looking at school-centered testing and surveillance strategies that are partnering with SQHC. Next slide. And then not just for federally qualified health centers, but also for all healthcare providers, we've been working on increasing use and increasing uptake of the electronic case reporting system or a provider portal that we have. And so this includes making some data collection modifications to an existing provider portal, so allowing it to be used for COVID-19 case reporting, and also to make sure that we're getting good quality data when that system is being used for reporting, and that we're getting all of the essential pieces of information, so including things like whether or not they collected the names of the close contacts when they counseled their patients, for example. And as I mentioned on the last slide, we've also expanded offering of remote training. So that includes this electronic case reporting system. We're doing additional trainings that are coming out of the HCC, the Hawaii Convention Center operations, to allow us to be able to put a lot more time, effort, and resources towards doing remote training for federally qualified health centers and other types of healthcare providers that might need some additional help getting set up or learning how to use the provider portal and do electronic patient screening. Next slide. And this goes back to Dr. Campbell.
This is actually Dr. Char.
Oh, Dr. Campbell.
Thank you. So you can see we're still very much focused on making sure that we have capacity to do proper testing, that our isolation and quarantine facilities are adequate, and that we're keeping up to speed and improving on the process of contact tracing. Number one priority for us right now really remains vaccination. It's a huge lift, and we're realizing that it's not just a Department of Health thing, it's gonna be an entire state thing. So to that extent, we've been working really hard on partnering with the healthcare centers, health professionals in the community, as well as the counties and nonprofits. It's gonna be a huge lift for our state. The prevention side is always the most important thing in public health, and to that end, it's a lot of messaging. We've been working with our communications team, messaging both for vaccination as well as for COVID in general. You know, the whole thing, we're getting tired of hearing the same old thing about wear your mask. But we've been doing some surveys to see where people are with that and you know, what kind of messaging resonates with them, and really, really trying to engage the community. Please wear your mask. The end is in sight. We can, you know, things will change once we get vaccination. That'll help greatly. And so if we can hang on till then, we'll be in a much better place than we are now. So really a plea to get the community engaged and to continue to, you know, keep up the fight, and everybody do your part for the community. That's all we have in terms of a presentation. I'm happy to entertain any questions you might have.
Members, questions? Senator Kim?
On your contact tracing page, where you have the number 578 cases that you couldn't reach, what is the total number of contact tracing? I can't lower the sound.
Sorry, I'm having a really hard time hearing the question.
So on page 14, where you talk about 578 cases or number evaluated, 40% didn't return a call, 40% no phone number, 16% incorrect number, 3% not available, 1% refused interview. So what's the total number of cases that you actually contacted?
So that would be slide 12.
I'm sorry?
So that would be on slide 12 right here.
12.
So basically 56% of the cases.
Yeah, what's the number?
that,
Instead of the
you know, were
percentage,
non-referred.
what's the number?
I think the number's on the left.
So 800
Yeah, I
cases?
can pull then.
Yeah, I mean, basically for most of October, we're looking at somewhere between a 55 to actually 63 to 68% reach rate. So when you look at that donut chart here, if 578 were not reached, and that's 40% of the cases, then you know it's going to be a high. I can't do the math in my head right now, but it's going to be a slightly higher number that was reached for that month overall.
So you're looking
The
at a,
ratios of reached to not reached are given in this chart here.
okay, so we're looking at an average of 60% you actually are able to contact, 40%, give or take, that you're not able to contact. Is that kind of the general rule that's been going on?
It's about 65 for the month of October. It was about 65% that we were able to contact, and then around 35 that we were not able to contact, or not able to get to complete the interview.
Okay, and then the number of, when you say that the Department of Public Health nurses, so how much contact tracing are the public health nurses really doing?
That's that differs by island. So on the neighbor island.
Just talk about Oahu.
Public health nurses.
So what on Oahu?
On Oahu, they're supplementing. So on Oahu, there are currently, for the public health nurses, it was 29 this week.
Right, but how, you know, you're looking at these numbers, but how much contacts do they actually make? Because you're giving us all these numbers, yet they're not full-time, right? I mean, we always have this issue. Every time we talk about contact tracers, we talk about, you know, how many are actual full-time? Of these numbers, what percentage of them are actually full-time? And if, you know, so can you break that down?
So anyone counted in these numbers has worked at least 3 full days that week. So we don't have anyone reflected in here that is less than 26 or 24 hours per week.
Okay.
So that's our cutoff. So there's, these numbers do not count anyone who works less than 3 full days in that week for us on case investigation.
So your public health nurses who are supposed to be working with the schools and so forth, they're spending 3 whole days doing these contact tracing and only 2 days doing their other work. Is that correct? Is that what you're saying?
This includes overtime. So we have public health nurses that work overtime, so we are cleared to pay them overtime.
So we're paying public health nurses overtime to do contact tracing. Can you give us what that amount is adding to? Because according to what I read according to what I read in the recent news, it says that Dr. Kembo reported Wednesday the program is currently overstaffed and will downsize to match demand. So why are we paying overtime? And that the State Department said it currently has 103 permanent staff, 194 contractors, 62 guardsmen, 32 volunteers conducting contact tracing. And the agency didn't say exactly how many tracers would be let go.
So a lot of the staffing is different roles. So what we've learned about contact tracing in the months that we've been doing it now is we need different functions within the contact tracing workforce overall. So we have somewhat specialized roles for the public health nurses in many cases where they may be assisting with things that require a nursing level of skill, such as following up with clusters of cases that occur in healthcare facilities. So there are focused roles that certain team members are playing. A lot of the manpower of contact tracing is in the first contact callers that Dr. Robertson can tell you more about. It's a different type of staffing, and that's where a lot of the greatest numbers are. This like the contracts with the city and county provide a lot of that workforce to make the calls to each case. But there's also a lot of investigation, and that's why we always say this is not just about contact tracing strictly in the sense of like identifying a contact and figuring out where they've been. It's about investigation, both of the cases and of the clusters that occur. And it takes a specialized workforce to do a lot of the investigation work. We rely, of course, on our core investigators and additional investigators we've brought on board. Some of those have graduated through the contact tracing program and been promoted to investigator status. But we also rely on the public health nurses for some of their expertise in particular areas.
Okay, so according to this news article, you told reporters Wednesday the program is currently overstaffed. So can you tell us how much overstaffed and in what areas?
So I feel like the quotes that came out of that really are not reflective of my main point. The main point is we've been learning from the process of contact tracing, and we're able now to look back and say which parts of this process are working well, which parts are the parts that really matter to get the job done, and which parts are not as effective. And so we're able to realign staffing, figure out which kinds of staff and how many we need to retain. And there's some pieces of this that are probably better used, those resources are better used elsewhere. We have a lot of other things that public health really does need to focus on at the same time, including vaccine efforts, and the PHNs, I think, are a case in point there. We probably will see less support from the public health nurses for contact tracing in the near future as they shift to the vaccination efforts. So I think this is a time when Department of Health really needs to think strategically, and we need to be able to look at the data we've collected in order to decide how we're going to structure our teams going forward, where we're going to put our resources. This is really a battle against COVID-19, and we have to think in that strategic way, like we're fighting a battle.
Thank you. I agree with you in that, but the information that you provide us, I hope that instead of just giving us this kind of numbers, which really don't really help us in any way, that you need to give us the more breakdown. And when you're giving information to the reporters or the public and saying one thing and then come before us and just give us this kind of raw numbers that's not drilled down, it just opens it up to more questions. So I hope you will provide us with the overtime, how much overtime you're actually spending, and where are you going to cut, because according to this it says that you're going to be downsizing to match the demand. So if you will provide that information, and then at what point, because I know I read that somewhere, what point, how many numbers, and I forgot what you said in your report to the media, that contact tracing is no longer effective when you reach so many cases. What number was that?
So once you get to a point where community transmission is widespread, mitigation measures are going to be the most effective strategy to prevent further amplification of the epidemic. We've learned this time over in all jurisdictions we've dealt with this pandemic. So it's the realization that at some point you're just continuing to
Right.
sprinkle a garden hose on a fire once it gets really big. You
So-
really need to shift at that point into public messaging.
So
into
what's
making
that-
sure
what's that
it's
number,
easy for
and when do
people
you
to
shift?
the right thing.
What's that number and when do you shift?
There's no magic number, but the number I threw out was at about 10 cases per 100,000 population. And our experience in Hawaii is where that balance seems to tip. And this is just a gestalt from our own experience, but that's about where it's not going to make much sense to try to have public health reach each and every case personally through a phone call. And even before then, I think we need to be pivoting to a whole of community response. And what that really means is like each person needs to have their COVID kit, their hurricane kit, their COVID kit. They need to know what they're going to do when they get sick. They need to know how long they need to be in isolation if they test positive. This is not secret information. It's really information we want everyone to know and be empowered to act when they get that result. And if we do that and we take it outside of Department of Health specifically, we're still coordinating this effort, but we need to engage the whole of community to get to that place.
Okay, I'm just trying to get at is at what point are we going to pivot? At what point? So, it's great you're giving us.
We should be pivoting immediately.
Yes.
We should pivot from the very beginning to empower people to have that ability to know what to do when they get a positive response. So it's not a strict number. There's a number above which, resource-wise.
So where are we?
Or resources into some.
Where are we in
So right
conjunction
now
with that number?
So if we look at, a rough count of 10 per 100,000, we're below that right now, but that's, we're on the edge of that. And so I think it is critically important that we're thinking about whole of community response now, about who actually is the first person to reach a case. It's not usually Department of Health, and that's not by virtue of not trying, but we are reliant on the results coming back to us. Whereas a person is the first person to know they get sick.
Emily.
They actually call their doctor, the doctor.
That's not Emily.
Yeah, Emily. So, but do those numbers allow us to go to a different tier so that we don't have to abandon contact tracing? So, what's the specific number?
Let me be clear. Just one moment. Let me be clear. No one is talking about abandoning contact tracing. It will remain a pivotal part of our response. And I'll hand
Okay, let me just rephrase that then. Where contact tracing is still effective, because you're saying that there's no sense in doing contact tracing once you reach that certain number. But what are the things that we have to do? Is that, do we go to a different tier so that we can slow it down? Do we do curfews? So that we're not at that point, that contact tracing is ineffective. So that's what we're trying to gauge, is what's that number, so that it signals to everybody else we have to take some action.
So the reason I talk about this number of 10 per 100,000 is really because these were the discussions we had, and looking from a business standpoint, from a community standpoint, from an education standpoint, looking at these tiers, that's sort of where that 10 per 100,000 number comes from. This is a point when we're in the red, and I think this is just helpful because it's framed in the same framework as the city
article,
and
she
county
says
mayor.
100
When
cases
we're in the
per
red,
day.
we really need to be using those mitigation strategies, and that's going to be our number one, our number one weapon against COVID-19.
So,
We can still be doing contact tracing. We certainly still want to be doing investigation, but those are not the most effective things to slow spread of disease in that tier. When we get into tier 2, that's where maybe contact tracing is having some additional synergistic effect, because we're having smaller numbers of clusters and more comprehensive understanding of what's going on. When we're getting down into tier 3 and 4 with many fewer cases, that's when you try to really be on top of every single case and investigate it all the way through. But, you know, I think where we've been at and where we have plateaued is closer to this tier 2 and tier 1 area. So I really think mitigation remains front and center.
okay. I mean, you responded, but I'm not sure if we have a specific answer as to what's that number.
According to what you said to Civil Beach, you said 100 cases per day.
Is that statewide, or is that just Oahu?
That was an example for Honolulu County, because that would be approximately 10 cases per 100,000 population. Again, it's not a focus on the number. It's a general sense of which strategies are most impactful at which stages in the pandemic.
No, I get that from your perspective.
Public engagement.
I get that from your perspective, but what we're trying to figure out is we have to get other components moving so that we can avoid getting to that number. So it's not so much a singular looking at it from your narrow perspective. We're looking at it, how do we get other departments, how do we get communications, how do we get all these other things so that we can help you stop the spread and not get to a number that's higher than what you're fearful of. That's why we keep.
A good way to think about it too is maybe just when we're talking about contact tracing, that's kind of referring to a group of different activities. And there are certain activities that we want to keep going even if we're only getting 1 case a day. Like, so, you know, if we have very small numbers of cases, we would still want to be investigating like any case that it happens in a long-term care facility. And we would still want to be like focusing on any clusters. So that piece of like the big contact tracing umbrella is going to be happening no matter what our case counts are. There are certain other things that through our evaluation and our performance metrics and a lot of the data tracking that we've been doing, that we've been able to determine are things that we can let go at this point because they're not having very good return on investment, big picture-wise. So I think when we're talking about certain pieces of contact tracing going away, it's not so much that we don't need contact tracing anymore, it's just that that's not achieving our end goal. There's kind of no point where we are going to start thinking.
Okay, so can you share that?
Where more cases happen.
Can you share that with the committee as the list that you provided? You said in certain areas it was effective, in certain areas it was ineffective, in certain areas you found additional data that helped. Do you have a breakdown of all those different components that you talked about? So that we can see where it wasn't effective, where it was?
Yeah, I think some of it we're working on putting into the performance metric side of the website for reporting. But other ones, Dr. Campbell, if you could go to the cluster report one. So what we're doing is, as we have additional, as we determine additional things that are maybe having high return on investment or low return on investment, one of the first places that we release those findings as soon as we have them is in these weekly cluster reports. So one example here with this week's report is we had highlighted that we were seeing transmission occurring in communities because workplaces were not necessarily providing us with employee lists in a timely manner. And so then as soon as we realized that that was something that was potentially causing more spread, then we're packaging it up in this kind of way that we can release it and sharing that with the public. We also had last week's weekly cluster report was focused on restaurants and bars. And so we additionally had some information like that we had determined where we might have different recommendations for different settings in terms of saying, okay, we actually have to quarantine this wider group of people if they're working in
Okay.
a setting.
Okay, so when we
On
went,
a small scale, we have that.
when we went to the convention center, you outlined for us that you had different teams, as you just mentioned, some working on churches, some working on schools. So I'm not sure if you have an updated organizational chart or at least a evaluation on each of the different teams as to where really you're going to focus on and where you really need just minimal amount of people because it's not as effective. I'm not sure if you have an updated chart that shows that.
I have been working with Dr. Campbell pretty closely on the kind of next phase of contact tracing and how what we've learned so far will go into that. So that includes which of those specialty teams I've recommended that continue and which ones seem like they have been very effective and teams that maybe we don't need as much. And so one example of a team that I have made the recommendation that if we are able to find funding to support, I think that it is worth keeping on is our Pacific Islander outreach and investigation specialist.
Okay, okay, thank you. So when can we get a copy of that? Because I think that's going to help clear up the perception that we're just going to reduce the contact tracing to lower levels.
And, don't get us wrong. We're not saying that we want you to
Let me clarify.
Well, let me clarify first. We're not trying to tell you, you need to keep X amount, because it's the Department of Health that focused on contact tracing from March of this past year all the way until July. So we're just holding you to what you folks have told us. Now, if things have changed and you don't feel it's effective anymore, that's fine and well, but we need to know about it, and you need to show us and show the public so we can be aware of these things. So, you know what I'm saying? So if you guys are finding that it's not working and we're spending our money, needlessly in certain areas, we don't want to do that either. But we need to get something more definitive from you folks as far as where it is we should be focusing on and what areas are we moving into that's more effective. And that's not coming through.
So the metrics that were shared, the metrics that we've just shared this week are this is what is helping us to analyze the work. So I want to be clear, it's not that we have been, doing ineffective things or pouring money into the wrong places, but we're learning as we go. This is all of our first pandemic, and we're learning as we go. So we are seeing now, as we examine the data, which parts of the efforts have been most effective. But it's not so much about cutting teams. It's more about the types of roles we realize have been most valuable in supporting the investigation efforts. And so it's not like the school team is going to go away. It's really more about which types of roles do we need to retain or build up, and which types of roles do we need less of. It's really just sort of operations when it comes down to it. I think for the more important factors for you to look at and see is to follow with us, as we will be following these metrics, to see if the changes that we're making are effective or not, and where we need to go next. I think it's going to be a living and breathing process, and the staffing will be in flux because we are constantly reevaluating roles and trying to staff appropriately to what we see. And that's where we want to be. We want to be in a place where the data can drive the way we're running our program.
Well,
How are you? how are you using, can you go to the position breakdown slide that you had earlier? The public health nurses versus the regular personnel for contact staff. At what point can we expect the types of analysis and the process you folks have articulated? At what point can we expect to see that incorporated into a transition plan away from the federal CARES Act resources onto the general budget proposal that the administration should be finalizing to submit to the legislature by the end of the month?
We have submitted some of those requests.
Oh, so those are at Budget and Finance awaiting approval, or they're on the governor's desk?
I
believe
believe
it's in the budget and finance. We're still working on it internally and submitting it. I don't think it's been finalized. It goes back and forth. We put in requests and gets modified.
For example, the 33 Hawaii National Guard positions that you have for Oahu contact tracing operations, are those federal funded positions that you contemplate transitioning away from? How are those incorporated into this, if you don't want to call it a downsizing, into a restructuring?
Exactly.
So,
Exactly. I think the word downsizing makes people alarmed.
Yeah, I never used the word downsizing. I think this really is a restructuring.
Okay, so when can we expect the explanation of that?
So if I may, because I had to do a lot of learning really quickly about this contact tracing. I thought I knew what it was and was very surprised that it's a lot more complicated than I thought. I think initially, before I started here, when somebody was identified as being a COVID case, an epidemiologic investigator would get assigned to that case. And that's kind of the rate limiting step. Those are the specialists. Those are the most highly trained people. And so we quickly realized that that's not going to work very well. So what Dr. Kemble and Dr. Robertson have done is restructured it to a team approach. And you kind of save those epi investigators for the really more high value complex cases that are likely to spark clusters and whatnot. And so they use a whole team approach. So initially it'll be a lower expertise, if you will, specialist kind of person. It's more of a entry-level person, if you will, that can help make the phone calls and get in contact with people. And then they make a determination if somebody falls into one of the priority groups. And if they're in the priority group, then absolutely, that needs to be a full-bore investigation. So knowing that, I think part of it.
I think that we respectfully, I think we get that part.
Yeah.
And part of that is because we've had this discussion with you folks for 9 months already, and I think your office, your department really should be commended. Particularly, some of the people on this call should be commended for the work that they've done to innovate the approach that was extremely rigid at the beginning of the pandemic. I used to wait tables. You send the busser to the table to greet the guests and give them water so you can buy time when it's busy. I get that those are, really breakthrough innovations when it comes to public health management in the middle of a pandemic when you're trying to adapt to the thing. What we have been asking, I think, though, is for an explanation as to how you're going to transition from the new framework that you've put together and is operating more effectively into this future reality come January 1 when there's no more federal support and we're projecting a surge. And I haven't seen an explanation of that.
The transition's already happening, though. I mean, it's sort of a continuous process, and I think that's maybe where the disconnect is, that it's hard for us to provide you a plan, because at any point in time, a static plan is only good for that moment. So this is contact tracing in particular, because cases go up and down. They fluctuate what the needs are. So some of the changes are more fundamental restructuring around, we continue to need to build investigator roles. So we're going to continue to build investigator roles. probably some of the neighbor islands need more investigators than they have now. So some things need to go up. Other things, some of the additional contact tracing staff we brought on are actually being absorbed into some of the investigation roles.
I just want to see the new work
Contact
chart.
callers relieves the need for a lot of those roles that we initially just called contact tracers. We're able to kind of break down the functions to more specific ones. And so really, I think what we'll end up with is a core staff of these sort of first contact callers that we can rapidly scale up or down to make that initial contact with cases, and then pass up, sort of set up the triage to pass that off to our core investigations team. National Guard has been serving really a coordinating and organizational role that has been hugely helpful. If we're able to retain that, we hope to, and if not, we will train other people into those roles. But those are the kinds of changes we're looking at to try to give you more insight. But it does change even week to week, and so even if you ask us for a plan for next week, it could be different in 3 weeks. And it really depends on what we're seeing in the 7-day averages and how we're doing with case burden. So it's a fluctuating process, and it's important that we build a system that's scalable. I think that's the main thing, is that we have a system that's flexible and scalable, because we're going to need that as long as we need contact tracing.
But we knew we need more investigators from June. I'm sorry.
What's that, Jared?
We've continued to build since June. We have a lot more than we did, but there's, that's probably the most hot commodity, is having the FE specialist investigators that have that high level of training.
But we knew that back in
It's not just a
June.
resource issue, it's a workforce
We didn't need a
issue
data
and
to tell us that. We
training.
knew that.
Regardless of whether the administration approves your request or not, the legislature is gonna need to see an articulated transition plan that explains all of this, so that we can figure out how to fund all of this stuff going forward. And I understand things are going to change and you're working on a framework, but that needs to be articulated, as soon as possible, regardless of the administration's position on what they put forward in a budget. Right? We need to work together to connect the dots on all of this. I appreciate the hard work, but we need to understand this stuff for budget time, and that's quickly coming up.
Give you this number, but this is.
Senator Kidani.
We have leverage. Sorry.
Thank you. I wanted to move on to cluster reports regarding schools, educational settings. And I'm looking at the one that was sent to us on by email. And this is a November 12th, 2020 cluster report. So some of my concerns is with the children back in school, I'm not sure what the DOH protocols are, and if you are working with the DOE to establish and make sure that the schools are following them. But is the Department of Health the ones that do the contact tracing in the schools, or are the school principals and administrators doing the contact tracing?
Shouldn't the school nurses be doing it?
Thank you. The schools, I think, are a perfect example of this concept of the whole of community approach to COVID-19 response. So it's both. So what we've realized and learned from our experience over the last 3 months, and we were just with Campbell High School today doing an on-site assessment and talking through this, we've learned that the first ones to learn about cases are going to be the schools. No matter what, no matter how good we get our turnaround times and optimal staffing at the health department, the schools are going to know first 90% of the time. And so what we've really developed, this working relationship over the last 3 months, is making sure our lines are open. They know how to reach us. We know who to contact there if we have new information. Information has to be able to flow both ways. And then in terms of reaching contacts, the schools are the ones who actually know where the case was when they were on their campus, have the best information on that, and are able to identify who the close contacts would have been. So what we've done is provide protocols to the schools and Q&As so that they can understand how to correctly identify contacts. We share the public health knowledge with them, but they do the notification. And so they're able to then provide the correct guidance to all the contacts, and so they have information on what to do. If they need to get tested, they're told to go get tested. And that partnership is where I see us actually being able to vastly scale up this concept of contact tracing through partner engagement. Because we can be, all these people, the other institutions can be extenders of DOH, and being able to make sure anyone who's exposed knows the right information and is less likely to transmit disease to others. Now, we get involved if there's more complex clusters going on. Of course, we're going to be serving as a technical resource, and that's why we are on the line with them to talk through if things are getting complicated. We can send teams out, we can do additional, more in-depth investigations to help solve that problem, and that's where the partnership is.
In this particular cluster report, you talk about an intermediate school who one individual, one student, had, I guess, was probably responsible for over 100. I don't know if they were all infected, but you guys had to do contact tracing. Part of this is the fact that the Department of Education has decided that they don't release the name of the school. They say it's HIPAA and FERPA violations, which our auditor said was not true. And so in this case, you guys have told us before when we visited that most people don't pick up the phones when you call because they don't recognize your number. I don't pick up phone calls from numbers I don't recognize either. But if the public were to know that they were in contact with individuals that went to this school or worked at this school, I think they would be more apt to pick up a phone call or to call a hotline or something themselves, so you guys wouldn't take the 2 weeks or whatever it's taking you guys to do that. That's, just my perception, and I'd like you guys to think about that. But the other thing is that the protocols, I'm not sure if you're leaving it up to the Department of Education or not, and you state that only one other of all these that you guys contacted was infected with COVID-19, one other student that sat directly in front of the student who was infected. But the schools, if you go to the schools, that's how they seat. They seat directly in front. They're not 6 feet apart. And so I think you guys need to reassess what is working in the schools now that they are back in schools. And I am very, very seriously concerned that because the schools do not have a protocol to follow, and if there is, I don't know where it was written, it is written because I can't find it, and the principals will tell you that they're not sure. So the other thing was that the student goes to different classrooms. So they're breaking the bubble that supposedly we thought they were going to be setting up. And so when you go from class to class, you are infecting everybody else in that class, the teachers, etc. So I'm asking if the Department of Health is going to come up with something that will be safer for the students and the teachers and the administrators in the school. And it's something that should be applied to all the schools and not left to the principals. They are not safety experts, health safety experts. And I'm just concerned that I don't think that the department has done enough work there. And I think all of us have heard the same things from their principals in schools, and as well as the teachers who have serious concerns. So I would really like you guys to take a second look at that and how we can do that better, because as the cases start getting higher and more children go back to school, we are going to have more and more cases if we're not following a protocol that is vetted by the Department of Health. The other thing I would like to...
I have a quick thing before Dr. Campbell talks to the bigger picture, but just to highlight for this vignette, just so we don't...
I'm sorry, I'm having a hard time hearing you.
Out there. So just so that we don't get inaccurate information out there, just to correct a couple quick things, is that the 100 individuals, those were individuals who we did contact tracing for. Out of all of those people, only one person was infected, even though all these other factors were in play with the moving to different classrooms, and the one student that has tested positive was sitting less than 6 feet away, directly in front of the person who was symptomatic. So all of that information was shared with the school and was again in support of the guidelines that we have provided about having people be more than 3 feet away, which was approximately the distance in this case. But for bigger picture, I'll just say for Dr. Kimball.
So are you
I
saying,
just wanted to say that
go ahead.
the school guidance is, there is one school guidance document that is available on our website. We have regular calls with the complex area superintendents where we've gone over that guidance. So that's been distributed to all of DOE and to many of the independent schools as well. And it does go through the spacing, mitigation measures, the mask wearing, cleaning, hand washing, all of those things. And we've taken to heart the need to understand the situation on the ground for the schools. So I just came back from the site visit today at Campbell High School. I've been to 4 different schools in the last 2 weeks on on-site assessments. It's been really helpful. I'd say my biggest impression is the amazing job that really the teachers have been doing in getting creative about creating signage, thinking about how to teach their classes about the mitigation measures, so that that goes way beyond the school. They end up taking that home and teaching it to their families, and that actually helps us in the community as well. Overall, I have to just say I'm really impressed with the work and thought that's gone in from the teachers, principals, and the complex area superintendents. So it's been really helpful to understand the specifics of each school, because there are different challenges for different schools, as you say, and that's really, I think the guidance was the starting place, but this ongoing collaboration to be on the ground together and solve the problems as we see them is really what was needed. It has been a very helpful collaboration that we will continue.
And I totally agree with you that the teachers have done a superb job of trying to wrestle the situation. But if you are going out to the schools, and we're not aware, we only are aware because you just happened to tell us that you were out at Campbell, but are you doing reports so that other schools and teachers and principals can see what corrective action you may have
Yes.
given to Campbell? Because I have not seen any at all.
Yes, and this is not really, there's not a lot of corrective actions. I will actually say, more to the point, I've seen a lot of great ideas that I want to make sure are shared between the schools, because some schools have found solutions that other schools are still struggling with. So that's something we've talked to DOE a lot about, and yes, we'll be issuing feedback to those schools, but also for DOE to share with the rest of the schools, and encouraging forums for them to talk through what they're experiencing on the ground, because really hearing from each other is some of the best ways where they can share that information and find ways to move forward.
You know, what I'm saying, they can hear from each other, but if they're hearing from DOH that this is a really good example of how it should be done, I think that carries much more weight than coming from other teachers or principals, because again, they are not the experts. They are doing the best they can. But validation from DOH goes a long way.
Yeah, I think the partnership there is really important.
So, can I also ask you that when you talk about the clusters that are happening in this particular report, are you looking at the 4 clusters that were linked to educational settings? The spread was within the school itself, or was it outside in related activities from school students? Or do you guys identify that as a separate?
We do determine whether or not the transmission was likely to have occurred in the school-based setting or associated with school-based activities, and that would be the clusters that are reported here. So it's not saying 100% sure that transmission did occur in that setting, but the results of our investigation at the stage that we are reporting them are that we cannot rule out that transmission occurred in that educational setting.
In your introductory statement on this November 12th report, you talk about a couple of cases. One was where elementary school, I'm not sure if there were teachers or workers, they ate lunch together and protocols were not followed, and this is probably where the cases started. So again, are they can eat together, but they have to social distance? I'm not sure what the protocol is for the teachers. Is it the same for the teachers as it is for the students?
Yeah, I can take that one. I'd say the break rooms and lunchtime is still in any, not just schools, but in any setting, the biggest cause of transmission that we see in other than household settings. And that's something, a theme we come back to again and again. So yes, it's going to mean for both. It's not just the students, the teachers have to think about it too. And that's something we've emphasized on every on-site assessment, and that'll be part of what we write up for DOE, is to really think about how, getting creative use of outdoor spaces, for instance, for those lunch times. And as much as people like to congregate and socialize at lunch, unfortunately during this pandemic, that's just not the thing to do. And making sure that message is really understood throughout the entire staff.
So is DOH or DOE providing updates or notifications that, this happened and this is how it could have been prevented to each school?
I'd say that's what we're trying to accomplish through things like the cluster report, to provide some specific scenarios that give examples and guidance for the future state.
So who does your cluster report
Although we do
go to?
Emily, can you move the mic closer to you? Emily, can you move the mic closer?
Yeah, better not the mask.
Yeah.
It's on my ear, the mic. I
Oh.
can switch my mask and turn up the volume.
Okay, thank you.
Yeah, so I'm just wondering how the teachers are getting
No,
notification.
wait,
of
I think
this.
she was going to answer.
Okay.
Emily, go ahead.
Yeah, so I was just going to add that additionally, during the investigation, the investigators work with the school itself and do share all of what they're finding out. So in the examples that are in the cluster summary that you guys are referring to right now, in that setting, then the investigators were working with the schools and saying, hey, this desk is not more than 6 feet away. This desk is only 3 feet away. So this probably contributed here. So let's help you come up with some solutions to how you can prevent this from happening in the future. So all of that is shared in real time during the course of the investigation as well. And then those lessons learned from that specific investigation are then shared with everybody through venues like the cluster report.
So shared with everybody, the cluster report goes to, who is everybody? I mean, how do the teachers see the cluster report?
It's available on our website.
Okay, could you
The
guys
cluster
share?
report is available on the website.
Yeah,
No, but I thought you said it's in the back.
Yeah.
yeah, I'm just wondering that maybe,
Every Monday you print it out, right?
yeah, but
No, but-
do the teachers know this? Does
Actually,
HSTA
Thursday.
know this so that they
Oh, sorry,
can follow up?
Thursday, yes.
No, but how do we make the cluster report a little more prominent on the website? Because Senator Moriwaki had brought to my attention that it seems to be hidden.
Way at the bottom. You have to scroll way to the bottom to get to it. So something up front so that we know where the
We can take a look at
clusters.
that and, sure, we can take a look at that and figure out how to make that. more
Because that's critical, because what Senator Kidani is saying is we don't even know. So you have the reports, but we don't see it. And no one knows that you've got to go way to the bottom of the report or the dashboard to find it. So if it's up front, people will now know, hey, I better look into the schools that are, it's clustering here, we've got to contain it, or, wherever else, the prisons or wherever else it's occurring. People are much more aware of what's happening around them with those cluster reports.
I just have two more
We
questions.
do have some community partners that are sharing it as well. So the city and county of Honolulu shares it on all of their social media, and I know that when I watched the morning news this morning, they were reporting out on the version that was published yesterday. So I think maybe anything you guys could also maybe do if you have like list groups or,
E-newsletters.
it's
Yeah,
getting
social
out in
media.
office. Yeah, things
Yeah.
like
Yeah,
that.
well, I for one would be happy to do that, but again, I never knew about these. I just happened to see them on the email that we got today. So my question now is, how many cases have to happen within a school during a cluster before the school has to be shut down? Is there a number? Is there a percent?
It actually depends on how much of the school is impacted. So it's not necessarily the case that because we hit a certain number of cases, the school will shut down. It's really about, are we seeing a clustering of cases in this classroom or this set of classrooms that might cause those classes to be out. So it's more likely that you're going to do this in a targeted way and say these classes have to be out because we see too many cases in these two classes than to say the whole school is going to shut down.
We still got safe travels.
So if that helps answer that.
Okay, and then that goes back to my concern that without the guidance and the principals, don't have that information. How quickly the contact tracing takes place is another determination of how quickly the clusters spread. And that's my major concern, is that with...
So in my experience, the principals that I've spoken with, and I've spoken to a number now, all do understand that they are the first ones to provide contact notifications and start that process. And they also have our number and they know how to reach us. So I do realize that we had some communication challenges back at the beginning, but I think those have now been ironed out. I'm constantly asking for feedback from DOE on this, and I'm hearing much better satisfaction with being able to reach us when they need us, and they know who to contact. And that's really the most important part. If those lines of communication are open, then we're going to be able to help them when they need our help. If they're not sure how to proceed in a situation, we can give them that technical guidance. But we also really rely on them to be able to pull those contact lists together quickly and get the notifications out.
That's correct, but I go back to the fact that the DOE does not report what schools they are in. They report by complex areas. And for instance, in my district, Mililani, the complex area goes all the way from Mililani to the North Shore. So the community is going to say, well, maybe it's not my school. I shouldn't, have to worry. Although I was at so-and-so school today and talked to so-and-so for half an hour, but I'm not going to be worried because it's probably not my school. And that's my concern, is that everybody should be...
I think the system, right. The system as it is now is designed so that we do quickly, between the school and DOH, we do quickly find out everyone who's potentially involved, and they get notification. So I would say to the community, rest assured that if you did not get communication, that you probably were not exposed. And so the real work is to making sure we do work together quickly when we first learn about a case to get the appropriate notifications out. That I don't want people throughout the community worrying that they might have been exposed just because there's an announcement of something going on in their whole complex area. But the process exists to make sure the people who need that guidance get it.
Thank you. My final question is there a requirement by the Department of Health or the state that any businesses that has an outbreak report the cases?
DOH does, right?
No,
We do
not if they don't know.
require businesses to report a case to us. What we do, and this is guidance that we need to, I think, emphasize more, so we need to get a push out now, is that we do expect to be called if you're seeing 3 or more cases in a limited area in a 2-week period. So that's our definition of a cluster. So for instance, what I mean by that would be like in a restaurant type of business, if you have 3 cases of staff that are working in the same work area in a 2-week period, that's something that Department of Health should know about, and you should pick up the phone and call.
Yeah, I don't think
So
private.
we'll be getting more guidance out to push that out, to make sure businesses understand what to do. This is also where our partnership with UH, we really want to also make sure, like, initially they helped us to get contact tracing staff trained. Now what we see we need is to train businesses, to train others in the community on how to be prepared when they get a case. And so that's the new direction with our UH partnership, is to really train up those community partners to be ready when they get a case. So not just schools, we've done that with schools, and I think you're right, businesses are the next area where we really need to be focused now.
I think that's important because I don't know that businesses know that.
Do call us as well.
Emily, can you repeat that?
I was just going to say that we also, that's part of our partnership with federally qualified health centers, is that they also call and notify us if they're seeing, kind of discrepancies or blips in their cases. So if they say we have 3 people who just tested positive at our clinic that all work at the same employer, they also call us quite regularly. And so that's another way that we're working with the federally qualified health centers to make sure that they're able to share information like that with us as quickly as possible as well, so that we have multiple ways to reach that to have that information reach us.
Thank you. Senator Milwaukee.
Yes, I want to go back to Senator Keoho Kalole's questioning on the restructuring. When we met with you, Emily, at the convention center, you talked about investigation, contact tracing as the team approach and settings. And when I look at the staffing on this slide, you've got people, I think, in total, DOCD, contact tracers, investigators, you've got 77. Everybody else on that sheet is like from other places, public health nurses, National Guard, City and County of Honolulu. So if we were looking at a team approach, and this is the restructuring part of it, and you're finding that that's effective in terms of containing and with your field investigators, containing the virus where it's found, and or preventing it through education from those settings, what is not shown here is everything that you've talked about is pretty ad hoc. It doesn't show up in how if we wanted to fund or support what you're doing, it doesn't show up because you've got positions from different places, and it doesn't really identify what the work is that needs to be done. So I'm asking, I guess, the same question that we've been asking is, what are you doing? How is it being done? Who's doing it? And what are the competencies that you need in these kinds of positions? So not only in this pandemic, but any other outbreak that gets large, we would have a team approach, and that is legitimized and codified in some way, that we start to do a new way of operating, and not this, top-down kind of approach, but one that is more horizontal and that can actually solve problems and contain the virus. So I'm asking if you have that kind of structure now that you're operating ad hoc-ish, put that down in terms of what are the competencies of the team that we need to look at, which is not just, Hawaii National Guard or public health nurse or City and County of Honolulu. That doesn't tell us anything.
We actually have that. It's our shelf plan that we've developed. It has all of those details so that hopefully if this ever happens again, then we do have every single position, the steps, how you ramp up and ramp down.
Emily, somehow you got muffled again. Emily.
Can't hear you.
Sorry.
She's saying there are plans written up for job duties and descriptions. I think we can work. We are still in the process of putting this into a cleaner format that can be shared. So the feedback is taken.
Could we have that when you've got it together? Because I think that's really helpful in terms of seeing what you're doing. Thank you.
Is that it? Okay, Senator Favela.
Okay, just going back to what Senator Kadani was saying for the schools, going forward and what you've seen or heard on the news going forward is the Department of Health working with the DOE, going forward, knowing that they're gonna be short of staff from teachers to custodians to EAs, and now the schools are gonna be lack of teachers, now we're gonna have overcrowding classrooms. The reason why I'm asking this is because I don't see no guidelines coming from the Department of Health for our schools. We let in the superintendent and we let the principals hold the bucket of everything, but right now, there's crunch time that we're losing staff members. Right now, at this moment, teachers are losing their jobs, classes are gonna double in size. Are we prepared in 2021 with the Department of Health, working with the DOE, are you preparing them or guiding them on what kind of preparation they should make? Because right now, nobody's talking about it. Because we're gonna have these kids go back to school with larger classrooms because we're gonna be lack on with custodians, people that clean the classrooms and keep them clean for the students, and we're gonna be lack of teachers. So how are you guys gonna give them guidelines with the DOE superintendent and letting them know what guidelines that they gotta follow going forward? Because we just got you talking about, you're saying 6 foot distance. How are you gonna 6 foot distance somebody when you get 40 kids in one class? You see, so I'm pretty sure you guys not preparing you guys so for that. Go ahead.
So we do have guidance. We do have guidance that was released in September and updated in October, and it's on the website and has been shared with all of DOE. They've also revised their guidance based on that guidance from DOH. And then, as I said, what's going on now is a process of walkthroughs, because as you point out, some schools are challenged with space. Some schools have different challenges about implementing the guidance. And we're trying to work together to help find creative solutions. Some of these things are not easy to solve. I mean, I think we all recognize that. So it is going to take some creativity and thinking about what interventions are going to be the most important to implement to keep the classrooms as safe as possible. And I think that ongoing conversation is going to be really important to help solve those concrete problems on the ground. But the general guidance is there. It doesn't really change. But as you said, if you have a 6 foot distancing requirement and you're looking at a class of 40 and you don't have that much space, how are you going to get around that? It might be meaning getting creative. It might be getting tents for the schools and setting up classrooms outside. It might be using the gym to convert into 4 different alternating classroom areas.
So Dr. Campbell,
So that you can maintain the distancing.
So I hear the list that you're going over what they could be doing. They have to be creative. I'm not sure if that actually gives them guidance versus just saying you can use one of these 5 options and then they can just choose one of the 5. But having to tell a principal or a teacher, go ahead and just be creative, I don't know if that's guidance.
What we provide are parameters, so we can tell you what we know about the virus and what makes it safer to do activities together. We know those things are masking, that they're physical distancing, that it's hand washing. So these are pieces of information are not new. I think the challenge you're talking about is implementation, and that's really something that the schools have to give input to, because they understand what they need to do to educate students, and then look at what is needed to prevent viral transmission and put those 2 things together.
But from a budgetary standpoint, to ask a school to just be creative, that could cost a lot of money. Versus if we have 4 or 5 different options, then at least DOE is able to purchase, plexiglass, the PPE, make space available out there in the playgrounds. They can make it more consistent, and so that we can properly plan for it. Versus just saying be creative, and that does without any money.
That's the process I'm seeing and that we're talking about in our on-site visits with the schools. So we're talking about all of those problems, and there actually are a lot of solutions out there that the schools have already thought of. Budgetary-wise, I defer to DOE on where the budgets come from for those interventions.
Yeah, no, so I understand that. So now when the principal given case on campus, are they still gonna call the superintendent and the CAS, or they call you guys directly?
That's a question for DOE about their protocols.
So that's what Senator Kidani just said. So now again, you're saying the DOE is setting the protocol, but isn't the Department of Health in charge of health? The principal is not health, not a professional. The superintendent is not in charge of health. So it's supposed to come down from you guys saying, if you guys have a case on your guys' campus, you need to call us. Not call about 30 different people.
Okay.
Go ahead, sorry, go ahead.
Our requirement in the school is that they notify DOH. The schools have to, DOE has developed their protocols about how they need that information to flow and where they need it to flow through within their system. So I don't administer that part of it, but we do talk frequently about the need for prompt notification, and that is happening now. So whatever they're doing is working right now.
So has there been a time where DOE's guidance is inconsistent with DOH, where DOH has to step in?
We haven't seen a lot of glaring inconsistencies. I think usually if there's tweaks to be made, it's released within the implementation details, and that's why getting involved with each outbreak when there is an outbreak is important, because those are lessons learned that we can then promote out through all of DOE so that everyone else learns from them, and make sure that difficulties in implementation are being addressed and that we're finding solutions.
Okay.
That's one more question. I'm going to go back to your cluster reports because I think they're really important. Because they tell you where the outbreak occurs and how many people are infected. And when I look at this, and I'm just, we saw some reports on the communication from the La Lima Alliance group, and it's very graphic. It gives you really like bullet point information that people find useful and they can understand. And this is not, I come from UH, so this is really academic in terms of when I see the December 3rd report that's on one of your sheets. It says key update clusters in food production and distribution settings. And it has good information there. What kinds of things you should do. You had outbreak of 2 and 26 cases. You can't do congregating and so on and so forth. But it's really fine print, and I can hardly read it. That, it's full of information that really should be bullet point, bigger print. These are things how you can prevent these clusters that are occurring in the food distribution areas in your workplace. We found these kinds of clusters. So I don't know if you can work with that group or with your communication group at DOH, but this is the kind of stuff on the dashboard people aren't going to really read and understand. So I just make a plea that if you're going to give information, this is noise, if you can't understand it. It's just like a lot of fine print. But it has good information here that really should be open and available to the public to see right up front of the dashboard. Hey, we have cluster outbreaks in the food distribution, in restaurants, or whatever, and this is what you can do to prevent it. That would be helpful for the public to prevent as well as contain. So I urge you to kind of look at this because it has good stuff in
Thanks
there.
for that, yeah. I think we need to find how to amplify that message through other channels too, so you're right.
Thank you.
Okay, so if we're done with the PowerPoint.
One more question. It's not nothing to do with the schools.
No, we still have safe travels and then the vaccine distribution.
Yeah.
So
I just wanted to ask you, when you go to the restaurant and you fill out the paper, what do they do with that paper?
I can at least speak to this for the city and county because I've talked with the city and county about this policy. I believe that there might be some differences by county, but I know for the city and county, per their recommendations to restaurants, then they request that the restaurants collect that contact information and keep it on hold for themselves in case we, the Department of Health, request it from them.
If there's a
Do they keep it permanently, or is there an interval that you folks have recommended they hold on to?
This is a city and county policy, so you would have to refer to their guidelines that they provide.
But to your knowledge, you're not aware of
should be
a
statewide.
period in
Yeah.
which they hold the information, they just are required to hold it. perhaps in perpetuity, it's unclear. Do you?
I would have to look it up to see, yeah.
So,
Okay, thank you.
so Emily, what if, why wouldn't you want it statewide? Because if the county says only 3 days, but Department of Health maybe needs it for possibly 7,
Yeah, why would
then it's not useful.
So I would just say that as of right now, our restaurant investigations, our investigations team that is specialized to investigations taking place in food service settings has not observed that to be a primary or prominent obstacle to any of their activities. So,
So is it even
as of
necessary
right now,
then?
we're really focusing on.
Is it even necessary?
I think that it definitely does not hurt, and it can potentially be useful, especially if we do experience a surge in cases. Then having that information readily available could potentially be of use. And I think that
If we can get
we're
it in
in
3 days.
discussions with the city and county and with the other counties as
You're not
well
gonna get to the
on
case in
how
3
to
days.
kind
You have
of
surgery.
standardize our recommendations, and again, how to use the data that we're finding to inform the recommendations going forward.
So use, with what you just said, why wouldn't you create a recommendation statewide as to the length of time the restaurant would need to hold that information so that it's useful for you?
I think my answer would be that I have other higher priority asks for restaurants and other entities that are more directly impacting our
What?
operations. So
Really?
I think the
I
recommendation.
mean, all it is one sentence saying to statewide restaurants, just keep it for 7 days. I'm not sure what you, if that's what you, if you think that takes a lot of time, then that's concerning.
No,
So,
I'm not
if
saying
I-
that
if
that's
I may
time
break-
to me.
If I could break in for a second, I mean, I actually think the reopening tiers, and one of the reasons I put them on the slides, I really believe that's been part of the success so far in Hawaii, because it does provide like a roadmap for everyone to think about. I know not everything on it is popular, but it's consistent, and it's provided that kind of guidepost for people. We're at a phase now where we have enough experience with the tiers and some of the details of what happens as a result of them to kind of now, same thing that we're doing with the schools, to go back and have those conversations and figure out operationally, what are the most important parts of this guidance? How can we refine it? And so those are conversations we continue to have with the counties, and that we do need to continue to talk about.
You know,
with the
Okay,
governor.
well, you-
But, you know,
We do get
what I don't get is that
standard policies out there.
if Department of Health is the fund, is where you're gonna need the information ultimately, not necessarily the counties. I'm not sure why Department of Health doesn't come up with the guidance.
If you let me just rephrase what I had said before. So basically, what I've seen with regards to our investigations that have taken place in these settings, the recommendation that was put out in this week's cluster report saying that we really need to make sure that employers are giving us accurate and timely information on employees, that was identified as something that was
That's not what we're
a
talking about.
priority and something that we really need to make sure that everyone's doing because we have had problems with being able to get that employee contact information in a timely manner. We have not necessarily experienced similar problems in other settings with other types of information. And so in general, when we're making asks to business owners or the counties or anyone, we want to make sure that we're asking because we have a reasonable expectation that what we're asking them to do is going to benefit our operations and is going to help us. And so if I don't have that reasonable expectation, even if it's one sentence and it might be easy for them to hold it for 7 days versus 3 days, I'm not going to ask that unless I have a reasonable expectation that I need that information and that that information is going to improve our operations. Because I want to make sure that when I ask them for things,
Yeah, but
they know
exactly,
that I'm only
exactly.
asking 'cause I really need
But
it.
did-
Exactly, it's you asking, so I don't know why you don't provide the guidance, because it's not that the counties are asking for that information.
Yeah, who decided that they wanted to collect the names? Was it the Department of Health? That the restaurants should collect the names?
So that is a recommendation as something that's helpful for us to, for both the business and for DOH to complete.
Okay,
contact
have you
tracing.
folks, okay, you've
So the
talked,
guidance comes from that concept.
okay, so you folks talk about, experience in collecting the data. Has anybody actually gone in and collect the data? Because frankly, every time I've gone into the restaurant, we've always questioned who should sign, whose name should go on. We put a bogus name, they put a bogus phone number, they never check it, they just pick it up, we don't know where it goes. And so I think what you're gonna happen is if you ever need it, you're gonna spin your wheels because you're not gonna be able to get hold of them. They're not gonna answer the phone, it's gonna be a wrong number, and you're just gonna spin your wheels. So again, is this a requirement that you folks really need when you don't even know how many days they should keep it or putting out guidance and whether or not it's working? Because it's not.
Our investigations lead has been going to restaurants and doing that, and also has been working with the city and county of Honolulu on the language of their guidance and of getting into some of those questions.
So what is that then?
But
Can you
Emily,
share that with us?
if you need the information, why don't you guys create the form so that it's consistent for every restaurant? Just one form that all restaurants know that they gotta use.
They don't.
Because every restaurant is different. Some restaurants, it's a notepad, others, it's a small form. And no one verifies. So it's getting to the point, it's getting to the point people think, oh, it's not serious. Or, you know what, it's not something that we really need to do.
What we do from a DOH perspective is provide both the scientific knowledge about the virus, how it's transmitted, and then what we've gained an understanding from the investigations that we perform. It is not our role to dictate exactly how businesses implement that, and I think some of that is a government role from the counties to understand how they're going to be, because they're regulating these businesses. What we can provide is guidance and feedback on the plans. I don't think our role is to dictate exactly how.
I think you're wrong. I think you're wrong. Dr. Kembo, it's the same thing with the masks.
We think you're wrong.
Same things with the masks. You let the counties do it ahead, and now we gotta do something statewide. I'm not sure why we're letting the counties experiment, and then all of a sudden you have to fix it anyway.
That's been the problem we had with your
And in
last
fact, we
director.
learn from different people's experience, but where I think Dr. Robertson's exactly right, where we see that something is showing in the data to have a large impact, that's where it's important for DOH to weigh in.
I get it,
That's
but-
where we
but-
can provide evidence-based.
But why do we even
guidance.
ask for it? Because you
Yeah.
folks are not following up
No,
and
so-
getting accurate data.
What you don't seem to understand is that
It's pretty clear at this point that it's not a priority for the
Right.
Department of Health to
So-
address
So why should we even do
particular
it?
management of the data that's being asked to be collected. But the Attorney General is on this meeting and is now put on notice that there are potentially emergency order actions being facilitated through the restaurants that could create privacy concerns because it seems like they're unnecessary. Okay, so
Yeah,
I think that the committee should take some steps to coordinate with the counties and make our position clear on this, because I think that there are some liabilities at stake here that now are a matter of public record. That there's an order in place, whether it's provided related to directives from the State Department of Health or from the individual counties, that businesses are being asked to collect personal information, and there aren't clear guidelines on why it's necessary and what the limitations are. So I'd ask the Attorney General to please look into that. And I think that we should probably, as a committee, take our own initiative on that, because it's clear that it's not a priority for the Department of Health. Can we ask about safe travels now?
Well, let me just follow up on one point, is that if we want people to take all of this seriously, then we need to take this seriously as well. Just being flippant about the restaurant forms and then telling the public later on, but you need to be serious. You need to focus on social distancing. You need to wear the mask. You can't just pick and choose when you want to be serious about something and when you don't. We need to be consistent with everything and be serious about everything if we want the public to be serious about it.
And I think one more thing
We're certainly not saying that it's not an important question. To us, what is a priority is making sure transmission is not happening in restaurants. And our job, as I see it, is to understand what's driving transmission if it is happening in restaurants, and make sure that we advocate for policies that stop that. You know, the details of the collection of information in restaurants is something we can revisit with the county and look at, you know, how much of a public health impact is that.
But we shouldn't-
I'm not saying it's something we want to be flippant about.
Okay, that's fine.
We need to work with the counties on that.
That's
but
fine.
It's really a policy decision that
That's
involves
fine.
the politicians as
I
well.
think one thing you have to be clear, what is the purpose of it? If it's to do help you with contact tracing, what is the period? Is it 3 days, 7 days, 10 days? That you make it clear and it's consistent, so it's based on a purpose and why you need the data, not just because the city asked. So I think that would make it clear.
And that's where I think, you know, we can weigh in on the rationality of a policy, and that's certainly something we can work on with the counties and the government.
So if you can look into that.
You know what, but that's the
again.
Attorney General's responsibility to make sure that these emergency orders are properly tailored, are narrowly enough tailored to address the purposes for which they're intended. I think, can we move on to safe travels, please?
I have one question, though.
Okay, go ahead.
That is totally separate. Can you guys tell us, what is the protocol by the health professionals and say hospitals like Straub and everything, when someone is diagnosed as being infected and have COVID, and they send them home, they put them on a taxi, but they don't tell the taxi driver that they have COVID? Is there a protocol that they're supposed to inform them?
That is not our recommendation to have you're speaking of a COVID positive person still within their isolation period?
Yes.
Yeah, we do not recommend sending them home by taxi.
Okay, so, but that's what's happening. So who's monitoring that? Because I'm being told by these people on the front line, nurses in these places, and they're telling me that they have these people that are infected, they're being put on the taxis. They don't want to tell the taxi driver because they're worried that they're not going to pick them up. And they don't know what to do with these people. So somebody needs to do something and fix that, because the next person that gets into that cab may get infected, or the driver may get infected. He's not aware of it. I mean, no wonder we're having all this spread in the community. I'm
This is
sorry.
the first I'm hearing of that particular complaint, so we'll look into it with the hospital.
Could you please and take it seriously, because the healthcare workers are telling me this, and they wouldn't be telling us if it wasn't true, and they're concerned. And we see the spread in the community, so somehow it's being spread. So we've got to get to the bottom of some of this. So can you guys report back to us on that, on the overtime, and on this whole, when you meet with the counties about the restaurant picking names, as to what's the status of that? We would appreciate that. Thank you.
I think so, yeah. Okay, why don't we move on to safe travel? So, did you guys have any report on safe travels, or do you want to just start with questions? Okay, Senator Keohokalole. Oh, Libby, you have something?
Yeah, so Safe Travels comes under the auspices of the Lieutenant Governor and General Hara as the incident commander. So the Department of Health role in Safe Travels is to evaluate the testing protocol and then to help the community with people who end up testing positive.
Okay, wait, can you just repeat that? So when it comes to safe travels, you're saying that Department of Health has a limited role with very specific actions?
Correct. It's not a program of the Department of Health. The Safe Travel program comes under the Lieutenant Governor and General Hara. And so there are a lot of pieces that are involved in Safe Travel. The Department of Health is responsible for picking up the testing, making recommendations with regards to what kind of tests are used and the intervals and whatnot. So all the health pieces, obviously, but
what about the overall health guidance? But the overall health guidance has to come from Department of Health.
sure. I mean, we are involved in the program.
Yeah, but I mean, so for instance, Department of Health has been, at least your position has been the 2 tests, having an entry test or a test later upon arrival, and that still hasn't happened, despite the fact that Department of Health internally has said that's something that we should do. So what I can't reconcile is, why aren't we following the guidance of Department of Health? I mean, that's why we have a department.
So, Senator, so we've been public about it. We have always held that we supported 2 tests for the travelers coming in. It's a policy call ultimately, and our point of view that we're representing is the public health standpoint. So the governor and others who make the decisions have to take into account other factors, but we definitely represent the health point of view, and we have always said that we recommend 2 tests.
Okay, well, I know members have I have follow-up questions, but I'll let members ask.
Yeah. I have a follow-up question. So although you provide public health recommendations to the decision makers in the administration, you are not the decision maker. Just to clarify, on November 21st, the CDC published travel recommendations. If I can read them, they recommend as follows: a pre-test 1 to 3 days before flight, a post-arrival test 3 to 5 days after travel, and 7 days, and staying home for 7 days after travel. So just so that we're clear, because there are a number of different 2-test proposals, is your recommendation consistent with the CDC guidance that I just referred to, that was published on November 21st?
Yes, we support having a test.
Okay.
And then retesting several days after arrival.
And so on December
that's not what
2nd,
this is
which is
for.
2 days ago, the CDC also came out and recommended shortening, well, they recommended a post-travel or a post-exposure quarantine period of 10 days. And so would you recommend, is your position that CDC guidance, do you take a consistent position with that? And should, from your perspective, we reconsider the current mandatory 14-day quarantine period in lieu of the Safe Travels testing program?
So what the CDC came out with is they came out with a couple of different recommendations, but that's as it relates to medical quarantine for close contacts of an infected person. So from the medical standpoint, we do support that. We support there's an option for, instead of a 14-day quarantine, for a 10-day quarantine. And the thought is that you will have people more likely to stay in the quarantine, and the trade-off is that there's a little bit more risk with somebody coming out at 10 days versus 14. We support that.
Okay, I have 2 more questions, because I know there are other members with questions. When it comes to 2 tests, you know, this committee was adamant that CARES funding be put in the budget to supplement the testing capacity of the state back when we were negotiating the appropriation of the CARES money in the summer. You know, that money ultimately went to the Department of Transportation Airports Division, in part because your predecessor declined, or their position was that the excess capacity was unnecessary. You know, since then, proposals have come through, procurement has been done, and the focus has been, my understanding is, on post-arrival nucleic acid amplification test technology, the PCR test. Which means if we implement a 2-test policy, we're talking about a PCR test pre-departure and potentially a PCR test post-arrival. Is it necessary, in your opinion, to have pre- and post-travel PCR tests? Or could, on one of those ends, a cheaper rapid test, different type of test apparatus or technology, would it still be sufficient to fulfill that 2-test recommendation?
So Dr. Campbell's probably more a subject matter expert than I am. I think the PCR test prior to travel is a good idea because it's more sensitive, higher sensitivity. Although we're seeing nowadays with some of the antigen tests coming out that the sensitivity is actually quite good. post-arrival, I think it's reasonable to use the antigen test as a follow-up test, but Dr. Campbell may have.
No, agreed. I think when you're getting into the sort of serial testing algorithm, the antigen tests are acceptable.
Okay, and just so that we're clear, what I'm reading, the bullet points from the CDC website here, they are recommending you get tested 1 to 3 days before your flight, 3 to 5 days after travel, and staying home 7 days after travel. Even if you test negative, stay home for the full 7 days, and even if you don't get tested, safest to stay home for 10 days after travel. Now, so this is, you cannot answer this, so it's more of a statement, but to date, we've had the CDC come out and recommend 2 tests. There's a consortium of medical professionals in the Hawaii community that have recommended a 2-test framework. You've come out publicly and said a 2-test framework is the most reasonable course forward. The Lieutenant Governor has since made statements proposing a 2nd test framework. And now we have deviation among the counties in terms of what safe travels actually means. Some are more aggressive than the current iteration of safe travels, which is a quarantine if you're not able to secure your test results prior to departure. Some are less restrictive, like on Hawaii County, where my understanding is if post-arrival you are able to secure your test results, you can be released from quarantine at that point. And then we have the city and county of Honolulu, which has the greatest incidence of disease prevalence and the most travel, that has proposed multiple different ways for a post-arrival test to be facilitated, whether it's through the UH laboratory or their testmobile. And to date, we have had no agreement from the administration as to whether any of those Honolulu County proposals would be approved of. How come we cannot just agree and recognize that a 2-test framework is necessary and then use the levers of government and the resources of government to figure out how to just make that happen?
Again, I mean, we're consistent. Please note that the CDC, those 2 things are 2 different things. So the travel protocol is, as you noted, with the test and then the test 3 to 5 days after and stay home for 7 days. That's different from the thing that they came out with regarding close contacts of known positive cases. And that's the 10 days. That's for a medical quarantine on someone that has been exposed. So it's a little bit different on those 2. I think what you're referring to. We've made a recommendation from a health perspective, but I think that's really a policy call for the leadership. And the counties, I guess, are enacting it at the county level, and that's policy level that the Department of Health can make recommendations, but it's a policy call ultimately, not a call.
So again, just to close up, if a cheaper 2nd test is potentially still a safe alternative post-arrival, then that's a different scenario than I think what has been contemplated, at least in the public discourse, because I know there have been many conversations between the administration and the counties, because I know expense is an issue. And because you guys kind of make a decision, I look forward to watching the House hearing next Tuesday, because it looks like they just posted and they will be inviting the Lieutenant Governor, the Incident Commander, and the Attorney General to explain the status of the Safe Travels program. So thank you.
Dr. Char, I have a follow-up question. On the CDC recommendation, it says 1 to 3 days before travel and 3 to 5 days after travel. So it really is not pertaining to 3 to 5 days during their trip. It's when they go home. Is that correct? This was pointed out to me, by the way, by someone.
Yeah, the way
We interpreted that as 3 to 5 days after arrival in your new location.
Okay, they're saying, and I'm not going to tell you where this is coming from, but it's coming from somewhere higher up here in government, that we are reading it wrong, you are interpreting it wrong, because it is to protect them from going back home and not infecting their home. So if somebody flies here from Philadelphia and they take the test, that when they leave and go back home, that they need to take a test 3 to 5 days after their travel, which then leads to the point where should returning residents, like people who go to Las Vegas and other places, that when they come back here, that not only they take a test before, but they'd have to take the test 3 to 5 days after they commence their travel to protect the spread. So is that not how you folks?
That has been our recommendation.
I'm sorry?
Regardless of how one decides to interpret the CDC recommendation, our recommendation would be for a test again after arrival. And that's based on the
Okay.
science that a test at one
Okay.
point in time is only a test at one
Well, the
point in
question
time.
was asked
They
on-
need a follow-up test.
The question was asked on whether or not we're following the CDC requirements, and Dr. Char said yes. And so
I would
that's,
say our recommendations are consistent with the CDC guidance.
okay, but if in fact the CDC is saying they need a test 3 to 5 days after your travel, not while you're in your travel, it's after the travel. So then are we consistent with that CDC?
I think it's still consistent, and maybe we are being more conservative than CDC, but I think both are necessary. So it also depends whether you're talking about
How are you being more
a resident who's gone elsewhere and come back.
Yeah, how are you being more
Because then you are
conservative?
talking about the test after,
Yeah, because this
because
does,
we're saying we want,
let me finish, okay? Because according to the CDC requirements that was told to me by some legal people here, it does not necessarily protect us. It protects them when they go back home to their state. And so it's our returning residents that come home here that this will protect us. So whether you're giving a test 3 to 5 days while the visitor is here, that's not what the CDC is saying. That 3 to 5 days is after
that's
the
what we
travel.
are saying.
Yes, but we're
That's
asking.
what we are saying.
I understand. But I'm also saying, how are we then being consistent with the CDC requirements that requires our returning residents, after they get a trip, that they're going to be tested 3 to 5 days after their travel?
But I don't think the CDC is recommending that we discriminate between tourists and residents.
No, but they're saying after their travel. They're not saying, they're saying after their travel is completed, they need to take a test 3 to 5 days. I got this phone call just before this meeting started. So I think we need to really take a look
Again,
at
I mean,
that.
whether, if,
Dr. Char, can you look,
that has been our position, that,
can you look into this? And
that,
can you also work with the Lieutenant Governor's office to see how they're interpreting it?
sure.
Thank you.
Further questions, members? Senator Keoho Kolole, do you have another question? If not, I'm gonna.
I guess not, because the purpose for asking about this was to just clarify, now that we finally have CDC recommendations that are clearly articulated on their website for travel, where the decision to amend these, the Safe Travels Plan or not lies, and then what the public health experts that are designated within the administration stand on it. So your position is that the CDC recommendations are sound, and so the deviation among the counties is probably not necessary, since there's unified guidance finally from the federal government. Is that fair to say?
I'm sorry, I missed the last half of what you said. So we are in agreement with the CDC guidelines.
Yeah, that's it. That's all. That's good enough for me.
Further questions? Paul? Okay, if not, thank you, Dr. Char, Dr. Campbell, Dr. Roberson.
So I
About the distribution of vaccine?
Oh, sorry, yeah, we
Yeah.
have one more. Sorry. Just because it's 4 o'clock, I guess I can't check out.
No, you have to stay.
Okay. So, Dr. Char, are you going to take that one, that agenda item?
Sorry, I didn't get the last question. Is there a question?
The distribution
what's
of,
the status of the vaccine plan?
The status of the vaccine plan? It is the number one priority of the department. We are working on it. We've done a couple of tabletops. We're expecting that 2 of the vaccines that have submitted for an emergency use authorization will likely get them within the next couple of weeks. And we're making sure that the hospitals are ready so that when vaccine comes down, that they will be able to vaccinate the tier 1, their frontline healthcare workers. There's a lot going on with vaccines. It is probably one of the biggest things that we've worked on, because it's not something the Department of Health can do. This really is an entire community effort. And it's going to take the healthcare sector, and it's going to take, the private sector and counties and everybody to get involved to make it successful.
So can you help us understand what are the challenges that you're trying to address in the plan at this point? Because if we're expecting to see distribution to healthcare workers and I guess the targeted priority groups for the end of the year, my understanding, then what are the major concerns that are keeping you up at night?
What's really different about this vaccine is it's not something you can just distribute across the community and individual providers can hold it in their refrigerator and just use it as patients come in. There are a lot of logistical pieces to this, and some of it has to do with the ultra cold storage requirements. So to find a freezer that can, store things at minus 70 degrees, that's a big challenge. And there aren't a lot of them in our community, but we have an adequate means to do it. We can repack it with dry ice. It's a very fragile vaccine, so physically it's not something you can really bump around or shake or drop or anything like that. So that's another
They're having a hard time
concern.
getting it.
One of the vaccines needs to be reconstituted before it's administered.
But Madera's one don't
But a
have
lot
to
of it
stay that
surrounds
cold.
that cold storage, and it also surrounds the manner in which it is shipped. So if the minimum order
And then you gotta take
and the minimum distribution for one of them is going to be 975 doses, we don't want to waste any of that. So you're not going to send that to a very rural place that's not going to be able to use all of that. And it's not something, because of the cold storage requirements, it's not something where you could just take a few vials out and send it over. And so just trying to match up the volume and the way the vaccine needs to be stored and the number of people receiving and the number of people, the providers willing to administer it, that's all going to be very carefully choreographed. So it makes it a lot more complex than other vaccines. Add to that you need a second dose of that vaccine about a month later. And if we get 2 different vaccines, we got to make sure that the person got the same vaccine on the second round that they got for the first dose. So there's just levels of complexity that are going into this. And then it's such a push to vaccinate, 1.5 million people. So that also adds to it. It's just a lot of logistical complexity.
So the National Guard was particularly helpful in addressing that logistical complexity when your contact tracing operation needed to be redone at your direction. Is that being contemplated? And then how much of the plan, between now and the end of the year is being facilitated by CARES money? So
National Guard helped a great deal in contact tracing, and they're involved in the vaccine planning as well. They're definitely a part of this. We have gotten some money from HHS up to this point for planning, but it's not a lot. We have been using CARES funding thus far, and we're hearing that there may be some more federal dollars coming down to help with vaccine distribution, but we don't know what or when, and so we're just going to assume that we just need to plan on our own, and at the point at which we actually get a set dollar amount, then great. We're looking at a minimum estimate, we're figuring probably about $25 million for the distribution of this. And so we have some other grant funding that we're setting aside to try and make sure we can do this. But again, we're hearing from the feds that by mid-December we should get another allotment, if you will, of some grant funding. We just don't know the amounts, and that's kind of the third thing that makes it so complex is we don't know which vaccine we're getting, we don't know when we're getting it, we don't know how much we're getting. And so that just kind of all adds to this, and yet we're trying to plan so that we're successful. When we get it, we can just turn around and get it out there.
So Dr. Char, go ahead. Go ahead, Jared.
Well, I just think that once you have a solid plan in place, and I understand it's a function of a number of different factors outside of your control. Well, perhaps we should have more, perhaps we need a briefing before the legislature, whatever body, given the point in which you're ready for that, to have an explanation of the steps going forward at that point, once there's some clarity on this.
Sure.
So, Dr. Char, are there consistencies in the different vaccines where, do they all need cold storage?
Madera doesn't.
So the Pfizer is a minus 70 degree cold storage. And so that's drastically different from the Moderna, which is a minus 20 degrees cold storage. But once you take it out of that, and if we pack it in dry ice, we still have a window. It's just that you can't keep it that long, but you can still keep it for 5 days, just with the dry ice, taking it down to that temperature. So again, it's nuanced, and with the dry ice, that buys us 5 days. That's a significant amount of time, but it's not as long as being able to store it for months on end. So that factors into it as well.
Dr. Char, I just want to build on that. I read that the distribution points will have to have the cold storage, and I'm just wondering who pays for that, so that each county would have some facility, or what does it take? What big equipment, or like you say, just dry ice? I mean, what does it take so that this could be evenly distributed, at least one site in each county?
Yeah, so that's part of the planning, is to identify, who has cold storage capacity at minus 70 degrees. And then serve that, we want to get the vaccine to the various counties. Where can it go that they can refill the shipper container with dry ice to extend the life for an additional 5 days? And that can be done a couple of times. Who has dry ice? And if we're going to be shipping dry ice from Honolulu to other counties, and that's all got to be built into it. So we're making sure that there's the capacity to receive vaccine on every island, to make, because it has to be in order to get it out to people. Once that vaccine comes to room temperature, we only have 6 hours to administer it.
So if we're getting vaccine at mid-December, do we have anywhere, there is a facility already being built, or do you
Well, when are you going to be done
capacity?
with your assessment of all those different infrastructure? I think that's more important, because at that point, we know what we need to budget for or use current monies for to build out that infrastructure. That's why I asked about the cold storage facility. So if you know you don't have some in certain areas, do we have to subsidize it? Do we have to build it? Do we contract it? When are those questions going to get answered?
We've done an inventory already to see where they have ultra cold storage capacity. Typically, it's going to be in large medical centers or research centers. Additionally, and this is where it makes it tough because the situation is always changing. It's come to our attention that some of the counties are trying to purchase smaller freezers, the kind of those small freezers you put in your office or something about that size. But the whole nation wants them, and so we don't know when they're going to be delivered. So we're looking at that as well. We just got a tip that there might be some that we could access through the federal system, so we're pursuing those needs. And so there's just so much that's changing so quickly, that we're following up on all these leads, and obviously, it behooves us to have this capacity, but we know that with the shipper and the dry ice, that'll give us 5 days. And we know that the first tranche of this is going to go to the major medical centers so they can vaccinate their frontline healthcare workers.
Dr.
So
Char?
have you been working with the, go ahead, sorry.
No, I was just going to say that when our committee visited the clinical labs and DLS, it's over a month ago, right? And they told us then that they knew how they needed that cold storage and that they were purchasing it. So I don't know if they have it yet. But my concern is that if we don't have it, does that mean we're not going to get that first vaccine that Pfizer is putting out? And would they send it to us knowing we don't have the storage capacity?
We have identified some storage capacity, and we are on the list and set to get vaccine as soon as we're ready to receive it.
Okay, thank you.
Jared?
Yeah, have you folks, so, back in the summer, we requested that you folks reach out to the FQHCs and the different community partners in priority areas to develop partnerships for contact tracing. Have those folks been engaged in this whole planning process? So that, if you work backwards from a vaccination distribution, a vaccination site, you can get some accurate numbers. Are you guys contemplating that? How, where you're going to actually give the vaccinations out in the community outside of those priority healthcare areas? And have you been working with those community partners just to figure out how many people are interested, how many people would come if you set up a date? Because it seems like this is a giant logistical operation, that's the level of detail and granularity you're gonna have to contemplate, right?
Yeah, no, you're exactly right. We've been engaging stakeholders from across the community for months now. There are several work groups, some medical advisory work groups. Sorry, ambulance in the background. That the FQHCs have representation on. There are prioritization and allocation work groups. There are provider outreach and enrollment work groups, training and exercise work groups. So we're definitely working with the community. We have a lot of partners. I think the meeting the other day, there were over 150 partners from all across healthcare and all across the medical centers and community providers and FQHCs on that call. And they've been having regular meetings. They're very much engaged. It's going to take the entire community to get this done. It really is.
Okay, if there's no more questions on the distribution of vaccine, why don't we move on to the last two items together? The recommendation of the second test, which we briefly talked about, and the quarantine from 14 to 10. Oh, so, but are you gonna make a recommendation to change that?
The recommendation was made today and went out as a medical advisory this morning and followed by a press release.
Okay, so it's from
we're
14 days to...
adopting the 10-day quarantine to 10, but not the 7-day test out.
Okay.
So when is that effective?
Again, just to reiterate, this is for medical quarantine for people that have been exposed. And what Dr. Campbell is referring to is that a medical advisory was sent out to all the physicians and healthcare community.
Oh, so it's not in the general.
Okay, can you outline what the advisory included?
Yeah, so it frames that we are, after review of the CDC guidance, adopting a shortening of the quarantine for close contacts of a person with COVID-19 to 10 days from the 14 days that it was previously. This does not apply to congregate residential settings. So that would be long-term care facilities, group homes, correctional facilities, other places where people are residing together in a congregate living setting.
Okay, so what about...
Others, quarantine can be shortened.
What about...
The understanding is, one important other part is that you still, because this changes the quarantine guidance, but not the incubation period of the virus. The virus decides that, we don't get to decide that. So through day 14, we're still reminding people they need to be symptom monitoring. If they're sick, all bets are off, they're back into isolation. And if they also must wear a mask and follow strict precautions during the remainder of that 14-day period.
Okay, so during the travel quarantine, you're still recommending 14, or you're now moving that to 10?
Our advisory does not address travel. This is for medical quarantine for a person who is exposed to a known case.
How does that make any sense? So we have a person who is known to have been in contact with someone that was infected, close contact. So now they only have to quarantine for 10 days. However, you get off the plane, you got a negative test, and you don't get it before the time you leave, but you still got to quarantine for 14 days. There's no evidence that you were even in contact with somebody that's infected, yet you get a longer period than someone who you know got infected. That doesn't make scientific sense.
Senator, I believe that'll probably, I'm almost certain that will be looked at the safe travel policy level. I think what Dr. Campbell's referring to, the medical advisory, specifically addresses the medical side of it. But I'm pretty sure that, I mean, it would make sense exactly as you're saying to look at it so at least there's some consistency on the travel side as well. But the CDC recommendation specifically is for those who were exposed, and this is a medical quarantine.
Right,
But you're right, it makes sense. I mean,
Right.
it stands to reason that we should at least look at it.
So is that something, oh, go ahead. Is
So
that,
as Department of Health, will you be advising the Safe Travel apps that it doesn't make sense to allow a person who's been exposed to someone positive, spend only 10 days, and yet someone who's not exposed and got a test, even though the test came back after, not when you arrived, that you still got to quarantine for 14 days? So are you going to make some kind of recommendation then, based on the science?
Sure.
okay,
It's a policy call, but it seems reasonable.
Okay, yeah, because to the general public,
It's really hard on the crowd.
doesn't make sense to them, right?
okay, so what you're talking about is,
Travel, but you never know when you get with people.
wait, I want to make it clear. What you're talking about is when someone arrives, if they didn't take a pre-test, that they would quarantine for 10 days versus 14 days.
Or even if they took a
So, yeah,
test and didn't get it back in time.
No, so I mean, all across the board, when does it change from 14 to 10, and when are we still leaving it at 14?
So we have made the recommendation from the Department of Health that for medical quarantine, that it get changed to 10. And what you folks are referring to with regards to the travel program, we can make the recommendation. That's a policy call. It seems reasonable, and I'm pretty sure it will be discussed. And it makes sense to me that if that were also changed to 10 days, I think that would be reasonable, but we'd need to discuss it.
And then, as Senator Kim mentioned, if you take a test, you only have to wait 10 days versus the 14.
You mean if you take a test, you don't have,
If
I'm
you
not
took the
following
test and got it back.
No, she's saying for medical, they're still leaving it at
travel
14.
policy.
No, she's talking about now. Let's say you take a test now. You would be quarantined for 14 days until you get your test.
If you get it
No,
before.
they said no, that you're not, as long as you quarantine for 10 days. Unless you're positive, then you got to stay there for the additional 14 days, right?
So after a person's exposed to COVID-19, we've always recommended that testing occur for close contacts to a case. So that's recommendation still stands, that we would recommend testing for anyone who is close
Yeah.
contact to a
Right.
case.
But-
This really just applies to, once you've been identified as a close contact to a case, whether you got tested or not, whether you followed that recommendation or not, your quarantine can end at 10 days unless you're in certain populations where you might put others in a congregate setting at risk.
So didn't
And
you,
that's not a test-based guidance. The 10 days is with or without testing.
could you clarify then, because I thought earlier when we were talking about the travel policies, the pre-test, the post-test, and 7 days, what was that? And I thought that was a
So
CDC
again,
guidance.
What I'm talking about is just for medical quarantine, so that the
Okay.
travel, I think the Safe Travels program will need to review the guidance as well and decide how that gets implemented on the Safe Travels side. So our guidance is strictly for the medical scenario of someone who was exposed to a COVID.
So I thought earlier when we were talking
we're asking
about
you for
safe
guidance.
travels, I thought that you had said that you were following the CDC guidelines, which was the pre-test, the post-test, and the 7 days.
No, they haven't required the post-test yet. That's not
Right,
required.
But that was what I
No,
thought
but
I
they're
heard.
saying 3 to 4 days after.
No?
We're talking about completely different things.
So what is so no recommendation that you have from the
Wait,
Department
she's
of
going to
Health?
clarify. Go ahead, Libby. Just say the two different recommendations.
Okay. Different things. So there are two recommendations that came out from the CDC. One of them has to do with quarantine for people who were close contacts and got exposed.
Yeah, the medical.
That's what Dr. Campbell's talking about. The other thing you're talking about is travel. And so there were two different recommendations. I think what you folks are asking, if I'm understanding, is because you're changing it on the medical side, does it stand to reason that we should change it on the travel side as well? And that's what I was saying, that I think it's, it's reasonable to discuss it. It all boils down to risk assessment, right? That's the whole premise of this from the CDC. So I think we need to look at the risk assessment for the travel side as well. Just on the surface, it seems reasonable that it could be consistent with the medical
You
side.
still gotta do
But
the
they're two
10.
different things. One is travel and one is
What it
medical.
So what is the travel, what is your recommendation
So if
for
you
the
don't
travel
get, but if you
policy?
don't get pre-tested, then you have to do the 14 days until you change it to 10 days. If you get pre-tested, right now, you don't have to do a
As
quarantine.
long as you get the result before you get on the plane.
Yeah.
If you get it the day you come back, they still want you to quarantine for 14 days.
So what is DOH's recommendation on how we should look at this travel policy in the pre-test, post-test, and quarantine? What are the
No, she
scenarios?
said already, pre-test, right? On top of that, you want,
Okay.
test several days after you arrive,
And
and then you can go.
so if
That's
you
what
have
they
a
would
pre-
prefer, sounded like.
They would prefer, but right now with the 10 days, it seems like you can quarantine for 10 and go.
The
But
10 days only applies to people who came in without the pre-test for the travel.
So it's 10 days.
But that hasn't changed yet, right? It's still 14 until you guys make,
Changed,
yeah,
right?
so it's still 14.
Until,
So are you making all these recommendations to the governor for the next EP, or?
Yeah, I mean, the CDC recommendation just came out, like within the past day, so I'm sure we'll discuss it.
Okay, because it seems like a lot of this has to happen quickly because there's so much confusion out there. Because we're already having a difficult time having people follow quarantine. I mean, we're not even sure, because of the Safe Travels app, people are not even following quarantine, and they're just telling officers, "Oh no, I got pre-tested. There's no way they can tell." I mean, we're getting lots of calls about quarantine violators still. Is that something you guys are trying to address? Oh, go ahead, Jared.
Because I'm confused now too. So the medical advisories are official Department of Health recommendations to the healthcare community that you have the full power and discretion and authority to issue in the interest of public health. The reason there's confusion is, and correct me if I'm wrong, you do not have the full discretion and power and authority to issue medical recommendations as they relate to the Safe Travels program. Your opinions and your statements today that are consistent with the CDC travel recommendations.
Yeah, they're not gonna change it.
Are just the department.
They don't have the authority to.
Individual position.
No, that's a good job.
They don't have,
That's
the-
good
you guys don't have
No,
the
no,
authority
honestly,
to initiate those as
Recommend to the
policy
governor.
for travel, but you do
But he
for
hasn't yet.
medical recommendations. Is that fair?
I think that's pretty close. So what we're doing on the medical side is guidance. We're providing guidance for the healthcare community. And what you're talking about on the travel side, it's the same thing. We will make a recommendation, but the ultimate call is not ours. We don't write the emergency proclamation. We provide guidance and we have discussions about it. The medical side, we're providing guidance for the healthcare community.
Okay, so when you make the recommendation to the governor, it's going to continue to be the second test along with 10 days. Is that correct?
Two different things. The 10 days, are you saying the second test and 10 days is all one policy?
Yeah, so if you don't take a test, you got to wait 10 days. If you take a second test, then you don't have to do the 10 days versus 14 days.
Conceivably.
That would be your recommendation to the governor. A second test or 10 days quarantine.
Second test, yeah. In general, yes, it depends on the other things that go along with that. Again, it's a risk assessment, right? And it has to do with compliance as well. So those will all be factors in the discussion on the travel end of things.
Yeah, but all along you've been saying we need a second test. CDC just came out and says you should do a test. So I would be surprised if you didn't continue to advocate that position. Now that the CDC actually supports you on that.
That's correct.
So then you would have, your recommendation to the governor is going to be a second test upon arrival, or after arrival, or 10 days quarantine.
So our recommendation would be a second test several days after arrival. That's correct.
Or 10 days quarantine.
Right, it would be a pre-test and then come in and then several days later do the second test. That would be our recommendation.
Yeah, and then they would have to quarantine until they get the results of the second test.
That's correct.
Okay. Okay, so I just had one question. Somebody asked if a visitor from California tests a positive after they arrive, are they part of the California numbers or the Hawaii numbers?
It depends on where the test was performed. So if a visitor who's not a resident of Hawaii tested out of state, and then we found out about a positive result after they got here, that's not counted in our current website numbers. It is a number that the counties are tracking and the state is compiling because we're interested in the number, but it's not counted in our website numbers. So we count either people who were diagnosed in
that's scary.
the state of Hawaii, or people who are residents of Hawaii who may have been tested out of state, as long as we can obtain their lab results. So a lot of the challenge is the consistency of reporting from out-of-state laboratories.
Okay, so up to now the governor says you have to show a negative test result prior to getting on the plane, right? So if they before that, if they took a test in California but they arrived in Hawaii and then they showed a negative test, a positive test, you wouldn't count those numbers even though they were positive here in Hawaii.
They aren't reflected in our website counts, but we are trying to track those to the extent we get the information. One of the reasons we don't count them on the website is we have very unreliable information on those people. But we're collecting what we can, and we'll prepare a special report on that.
Okay, but so that means the numbers may be actually higher than what's actually reported because you're not counting those if the test was taken in another state.
That is correct. The potential number of positive individuals who arrived here could be higher than what's reflected on the website.
Because, for example, I have a returning resident who took the test prior, came back though, didn't get the result, and 10 days later, they still haven't gotten the result. As of today, that they have not gotten the result. And it's been 10 days. And so if it comes back tomorrow and it's positive and they're a resident, you're still not counting it.
A resident, we would count it if we received
You're
it.
talking just the visitors.
Or just the visitor.
Yeah.
So even though that resident took the test in California, you're going to count it.
Right.
Yeah.
As long as we get the reporting. But again, that's part of the challenge, is getting the reporting from the hundreds of labs that are doing testing for COVID on
Yeah.
the mainland right now. We capture just a percentage of those.
Yeah, that's
So
why.
if they tell us, then we'll count it. But they don't, they aren't obliged to, it's hard for us to know if somebody's telling us if they've tested out of state.
No,
We get an
yeah.
electronic report from that
Yeah,
laboratory.
because they're waiting for the test.
Yeah, so that's what some of the mayors are talking about, is they're getting visitors who end up being positive,
They say they're.
but they're not part of the numbers, so the stats that they're providing are actually
And they're
false.
saying travel is not.
So the numbers are actually higher
The stats we
because,
provide are what, right, the stats that we provide are what we are able to capture, but we think it's important to recognize that there are some cases we do not capture through electronic reporting, and so those would not be reflected on the website. And they're still important for us to understand what's going on in terms of imported cases.
But I thought we were requiring everyone coming off the plane to let us know whether they've tested or not, whether they're returning residents or visitors.
Right, and who would know if somebody decided not to upload their result, I guess is the problem.
But why go through all the trouble at the
And
airport to
somebody
do
lies.
this if they can walk off the plane without reporting?
No, but some of them don't get the test back.
Wait,
That's the problem.
wait, Dr. Char, what were you gonna say?
Yeah, like Nancy, she came back from her trip
So
and
that
she's
was-
still waiting for the test.
That was part of the push in the change that you have your negative test results and you upload it before you travel to Hawaii. That was to help minimize those people who took a test, don't have their results, land on our shores in our state, and then go, oh darn, my test result's positive. And if they don't upload that or hide it from us, it's really challenging for us to
Yeah,
know.
and then they're out
And
there
some of them
spreading
are
it.
coming to our attention.
Yeah, but in those
Because they would
cases,
be in a hotel and they would sit and they need help lodging, and then that's how it would.
Put it on silent.
So that was part of it, to have your test results before you come to Hawaii, that would help us to minimize that from occurring. It can still happen, people can lie, they can say, oh, I never took the test, I'm just gonna go into quarantine. You know, there's a number of things that can happen, but it's been helpful. We know that some of the people who didn't get their test results back are canceling reservations at the last minute, and I know that from a public health standpoint, that's good. From a hotel standpoint, they're not very happy about that.
no, but so my concern, Dr. Char, is that people can get off the plane without being tested, and then, but they're supposed to be in quarantine, right? But we're not tracking whether or not they are in quarantine. Is that correct?
Well, the Department of Health doesn't track them. I believe that's because that's a travel quarantine. I
It's a
believe
safe
the
travel
counties
people.
are responsible for that. And I don't know all the legal side of it, but I don't think we can deny people travel to our state.
there.
I think that has to do with the federal law or rules or something.
So do you go back and adjust the stats then? So yesterday, or let's say last week, the state might have said the rate of infection was lower, but then you get all these results from the mainland after the fact. Do you go back and you change those stats, update them to show that the rate of infection was actually higher?
So those, as I said, if they're not a Hawaii resident, we don't get their results, so then they don't get counted on the website.
Yeah, no, I'm saying, so after the
We are
fact,
aware.
after the fact.
No, we still don't, like, we hear rumors about positive people and sometimes we have to intervene, but we're not getting those reports electronically into our reporting system, so they don't get counted on our website.
But Dr. Campbell, there's a convention, right, that by the CDC that where, like, if I take a test in California, I'm counted in my home
They're
state.
counted in California, that's correct.
Yeah, so
So they're counted in their home state.
but they're still
Of course, we
positive here in
realize
Hawaii.
We realize they pose that issue, and that's why we track these numbers through a separate system right now. But it's not part of our reporting system. It's just the structure of our reporting system.
Okay, do you think you can report those numbers in addition to what you have now?
We're working on a specialized report so that we can look at the experience since the opening of the Safe Travels program.
Because I think that would be important.
So we're trying to keep track of that bucket of numbers, if you will. But as Dr. Campbell says, it can be real challenging to get that. So however we get it, if we find out because somebody, calls and needs help because they need hotel room, whatever, we're trying to keep track of all of that, however it comes to our attention. And we know it's underreported, but we're trying to capture that as best we can.
Yeah, I'd like to just ask what you're doing with the travelers, if in fact they're positive and because at one point, I think in April, and I don't know if this act is still, being sought after or adjusted, but a visitor would come and then, it's like a GPS and you would know where the person was so that if a visitor didn't know where he was, at least in terms of contact tracing, you'd be following up on them even if they're not our resident. You want to know every positive case and who they've contacted. So I don't know, how are you working with that for out-of-state travelers who test positive? Are they confined and do you watch them or what?
Yeah, if somebody.
My understanding is that's part of how the Safe Travels app was designed, to have like that green face or the red face. So if they didn't get clearance and the hotel asks for it, they can see that it's a red face. I think that was the design to try to implement the quarantine for those travelers.
So you are tracing contacts of these non-resident visitors who test positive?
If we learn that a visitor arrived and is positive, if they come to our attention, then we do put them into our system for investigation and contact tracing, and we'll follow up to try to learn if they have contacts. Some of these travelers, some of the travelers, however, have been fair to work with, and they may not share information freely. So that's been a big challenge for us.
Did you folks do the couple that went to Kauai? You put it in your system? The couple that got on the
Again,
plane?
I can't share details of specific, I can't share details of specific cases.
Was that in your
We follow up
count?
whatever we're notified of.
Is that in your count, or is that in the count?
I can't speak to any specific case, yeah.
No, I'm just asking if you counted them. I mean, you're not specific case, it's just, are they counted?
I don't know which, I don't know which specific travelers you're referring to, so I can't tell you if they're
The-
counted or not.
the
but
couple that-
I'm telling you how we count travelers
Okay, so
is
the,
based on us receiving a report, and if it's somebody tested in the state or a resident tested out of state for whom we received a result, they go into the counts on the
so they're
website.
residents,
I
right?
believe the cases she's referring to were Hawai'i residents
Right,
that tested out of state and then
So they,
flew well infectious.
so they should be counted here.
so they're in your numbers.
Yeah, but what's concerning is all the people who are tested, non-residents who are tested out of state, and we don't know, we don't have those numbers.
How about all the people that were sitting next to
We are
them
equally
and exposed?
concerned, and even for the ones that we do know about, we suspect there are more which we don't know about, so that is of concern to
Yeah.
us.
So Dr. Campbell,
And have the recommended changes to the Safe Travels program to require the test result before boarding.
So-
I'm sorry, but I gotta go pretty soon. I got another meeting pending and I'm late for it.
Okay.
Okay.
Okay, wait,
Thank you.
so you just have a question for
Yes.
Dr. Kimball?
yeah, I can ask
Okay, thanks,
Dr.
Libby.
Campbell this question. Thanks, Libby.
Hi, thank you, Libby.
Wait, I have one Libby question. One,
Oh, okay, hurry.
one more. Okay, safe travels coupled with the vaccination. At what point are we gonna start talking about what the guidance should be for individuals who can confirm a vaccination as it comports to safe travels purposes?
Yeah, we've already started having some informal conversations on it. We'll definitely ramp that up. But again, it's gonna take you getting 2 doses of the vaccine a month apart. So we're probably looking at the end of summer by the time that happens for the general population. And then there's a lot about the vaccine that we don't know in terms of characteristics and how long you have immunity and all that. So we're gonna have to take all of that into consideration as well.
So reasonably not for probably a quarter. Okay, thank you.
Thank you.
Senator Kidani?
So, Dr. Campbell, is it safe to say that local residents, then, if they decide to go visit hotels, whether in Waikiki or any place, they don't know that the visitors in those hotels, whether they're tourists or residents that have returned, they don't know that those are all negative tested people, because we don't deny anybody to come into the state if they don't show a test. A negative
Correct.
test.
Correct, but the expectation is that they would still follow travelers quarantine if they came in without a negative test.
Well, if they weren't going to test, I hardly expect them to do that, to be honest, and I think you guys probably believe the same thing. So my question then is, there is no protocol with the hotels that accept visitors to make sure that their other guests are safe from visitors that may have positive tests, or may be positive but don't have test results at all?
Well, we've recommended to the hotels all along, and what I hope they're doing is still implementing all the mitigation measures. So even if you have visitors at the hotel and maybe their test status is unknown, you know, hopefully they're compliant with quarantine. If they're not, if they're masking and making sure that in the hotels people are masking in those common spaces, that's your protection against transmission in that sense.
There's no oversight.
So
Yeah.
that's why the general mitigation guidance is so important everywhere, because if everyone's doing it, that does a large part of reducing transmission risk.
Yeah, but I guess what's alarming to me is that the general public does not know this, and they're trying to help local businesses and the hotels by, you know, renting the rooms, because the hotels are,
Restaurants.
and restaurants are offering, you know, Kamina rates, et cetera. But what the general public does not know right now is that there are hundreds of tourists walking around that we do not know because they did not have test results. And if they were positive, there's no way that we can check whether or not they're quarantining.
Moreover, I would remind you too that someone who did get a negative pretest could be walking around and could be infectious today because it's 5 days later and nobody tested them again.
That's correct.
So that's
yeah.
our concern about the second test.
That's correct. I think what bothers me is that when we first started this process, we kind of were led to believe that we were sort of catching everybody, and the hotels were reporting to the police when the people who were supposed to be in quarantine left their rooms, et cetera, and apparently that's not happening anymore. So we're not as safe as we probably used to be, and I think the general public out there needs to know. And if the hotels out there are not willing to do the check, do the test, or make sure the quarantine, the positive people that are here are not quarantining themselves, then the public needs to know that.
So Dr.
I
Kimball,
think the hotels are in it. Yeah.
when you talk about the stats, then do you put the caveat that that these numbers don't reflect all these other populations that we're talking about? I mean, I would hate for
We've always reflected, we show in the website what we do count, which is people diagnosed in the state of Hawaii or residents diagnosed out of state. So that's always been noted. in our
Okay.
Visualizations. What I wanted to say about the hotels is I do think the hotels are potentially in a situation to help implement at least parts of the quarantine, you know, by having ways to require checking on that app, and if they're gonna, you know, go check in at the restaurant, you gotta show your green face emoji. So those are some of the things that I think hotels can be doing to help implement that.
Mhm.
But again, that doesn't address.
But there's
the
no
fact that a
oversight.
negative test on the day
Yeah.
before you
Yeah.
arrived, right, doesn't necessarily mean you are
Yeah,
staying.
but has the Department of Health actively met with the hotel management, and has there
We have.
been any of that?
So we've had multiple connections. I'm sure that Dr. Kemble could speak to division level meetings, but I know disease investigation branch, we have had meetings. I have had meetings with different hotel management leadership, and then additionally, there's been lots of ongoing communication between the investigation teams in terms of providing guidance and information. And, you know, there's a lot of back and forth going on there of us working with them and us keeping in close contact with them as well.
So when are you going to make available that extra bucket of information to supplement what's on there now regarding the positives that arrived that are not identified early?
We're working on it. I'm reviewing the data. I want to make sure that it's as accurate for as it can be. So we're working on getting that out.
Okay, so and how does that, because it comes across misleading when it shows that we have a lower percentage rate when you are not counting all these other out-of-state test results.
Well, one thing I'll say about percentage rate, we won't have that because we don't know how many of the travelers got tested before, you know, so some people we're learning about the ones who we happen to learn about, like who either shared their result or for some reason they got caught out. But we don't know the total number of people who got tested and which ones we're finding out about. So either way, we couldn't add that to like our percent positive rate because it's sort of a different group, it's a different subset. So the best way to think about the percent positive rate is from a subset of tests where we know who's getting tested. And that's the electronic reports that we receive. So we're always going to be basing percent positivity on our electronic laboratory reporting.
Tell her she can hang out. Okay, we just got a letter from the Attorney General asking us to wrap up, but if she has to go on, she can just hang up. I mean, if members have questions, we can continue.
Sorry, I need Dr. Kemmel in this meeting that we were supposed to be at 1 o'clock.
Okay, any other questions then? Okay, you know what we'll do then is we'll just try to continue the conversation and possibly post for another meeting so that we can continue. So, okay. Thank you.
Thank you.